Please silence your phone. Please go up to the Sergeant at Arms desk to fill out a testimony slip. Written testimony can be emailed to testimony@council.nyc.gov. Again, that is testimony@council.nyc.gov. At this time and going forward, no one is to approach the dais. I repeat, no one is to approach the dais. Thank you for your cooperation. Chairs, we are ready to begin.
Thank you, and good morning, everyone. I'm Councilmember Crystal Hudson, Chair of the Committee on Aging and Co-Chair of the Council's LGBTQIA+ caucus. My pronouns are she, her. Thank you to Chairs Schulman and Narcisse for co-chairing today's City Council hearing on older adults living with HIV. It has been nearly 2 decades since the Council last held a hearing on the needs of older adults living with HIV. Since then, the challenges faced by this growing community have only become more urgent. I want to especially thank the advocates and members of the public testifying today for their patience and flexibility in the lead up to today's hearing. With the development of effective antiretroviral therapies, or ART, in the mid-1990s, HIV became a treatable condition. Previously, tens of thousands of New Yorkers went ignored and failed to get any support from their federal, state, or local governments. As a result, many New Yorkers living with HIV never had the chance to age and become an older adult. Now, people who regularly use ART can attain normal or near normal life expectancies. As a result, older people with HIV are increasingly dominating the HIV landscape. Approximately 60% of people living with HIV in the US are now over the age of 50, with that number expected to reach over 70% by 2030. Because of the success of ART and the prevalence of safe sex education and interventions like PrEP among younger individuals, people 50 and older now likely make up the majority of adults with HIV in the US. The growth in the population of older adults with HIV is also fueled by new infections. In 2018, 17% of new HIV infections in the US were diagnosed in people 50 and older. In New York City in 2021, older adults 50 plus comprised 17.1% of new HIV diagnoses. Among US states, New York has the greatest number of older adults living with HIV. As of December 2020, New York State was home to approximately 59,000 older adults with HIV, of which 44% were Black and 27% were Hispanic. In 2020, Black older adults made up 46% of new HIV diagnoses in New York State. The data says it all. The extreme disproportionate impact of HIV on communities of color, and specifically Black older adults, could not be clearer. Given the current and projected growth of the population of older people with HIV, it is imperative that we adequately support this growing community and develop an effective policy response to address their unique needs. However, due to ageism and other factors, older adults living with HIV have been made to feel largely invisible. Older adults with HIV face many obstacles to accessing and staying in HIV care, such as discrimination and stigma, a lack of insurance coverage, transportation issues, or inadequate social supports. According to a recent report published by the Brookdale Center for Healthy Aging at Hunter College, the most frequently expressed service needs among older adults living with HIV in New York City were socialization at 54%, personal or family counseling at 42%, help with accessing benefits and entitlements, 41%, someone to call or visit regularly, 31%, an escort to a healthcare provider, also 31%, or help finding a job at 28%. We have a moral responsibility to care for older adults living with HIV in New York City, and I look forward to learning more about how NYC Aging is addressing the specific needs of this growing community, whether through visitation programs, phone check-ins, case management services, or other initiatives. As co-chair of the LGBTQIA+ caucus, I believe that we must do more as a city for our older adults living with HIV who are also LGBTQIA+ identified. Earlier this year, the LGBTQIA+ caucus released the Marcia and Sylvia Plan, which advances a bold vision to lift up LGBTQIA+ New Yorkers and all people living with HIV, including older adults. To help older adults living with HIV, the plan calls for building more LGBTQIA+ specific housing for older adults and setting aside housing for LGBTQIA+ older adults and older adults living with HIV, mandating LGBTQIA+ HIV anti-discrimination and competency training for all older adult service providers, providing free sexual health and wellness programming at older adult centers, and ensuring all New Yorkers have access to free PrEP/PEP regardless of insurance status or immigration status. And earlier this week, the Council passed Introduction 564A, which requires the creation of a commission within the Department for the Aging to ensure that NYC aging programming and services are inclusive and respond to the specific needs of LGBTQIA+ older adults, including those living with HIV. I look forward to supporting the work of this commission and working with NYC Aging to implement its recommendations. Older adults living with HIV have been ignored and mistreated by policymakers and healthcare professionals for decades. That's why we're considering important legislation by Councilmember Sanchez, which would expand the availability of rapid testing for sexually transmitted infections, as well as legislation by Councilmember Ossé, which would require the city to conduct outreach and report on the distribution of PrEP medication. And while I'm grateful that New York State now requires insurance companies to cover PrEP and PEP, my resolution, Resolution 395, calls on the state to pass Assembly Bill 5995 and Senate Bill 3297, which would allow pharmacists to dispense PrEP and PEP, as well as Assembly Bill 6059, Senate Bill 3227, which would prohibit health insurers, health care plans, and HMOs from requiring prior authorization for PrEP. In the wake of countless attacks on access to health care across our country, we must ensure comprehensive and equitable access to HIV prevention services and treatments in our state and in our city. I also want to note my legislation we are considering today on MPOX, Introduction 620 and Resolution 294, and I look forward to discussing with the administration the ways in which we can improve outreach and public education around vaccination and treatment. MPOX remains a serious concern in New York City, and I encourage eligible New Yorkers to get fully vaccinated. Vaccination is free and available regardless of immigration status. And to learn more, please visit nyc.gov/health. And before I close, I want to share some important information from the NYC Health website. An HIV test is the only way to know if you or a partner has HIV. Free or low-cost tests are available for anyone 12 and older at NYC sexual health clinics, regardless of immigration status. You do not need to have consent from a parent or guardian to get tested. Getting tested and knowing your HIV status is the first step toward taking care of your health. To find a testing location, please text TEST NYC to 877-877 or call 311. Thank you again to Chair Schulman and Chair Narcisse. Thank you to the advocates and members of the public who are joining us today. And thank you to representatives from the administration for joining us. I'd also like to thank my staff, Casey Addison and Andrew Wright, and Aging Committee staff, Christopher Pepe, Chloe Rivera, and Samuel Hamid. I'd like to acknowledge we're joined here today by Council members Ossé, Marte, Menon, Sanchez, Narcisse, Schulman, and Areola. I will now turn it over to Councilmember Schulman, Chair of the Committee on Health.
Thank you, Chair Hudson. Good morning. I am Councilmember Lynn Schulman, Chair of the Committee on Health and a member of the Council's LGBTQIA+ caucus. I want to thank you all for joining us for today's hearing, which is long overdue, as the last time the Council held a hearing on the experience of older adults diagnosed with HIV was in 2006. That is why I am proud to chair this hearing alongside Chairs Hudson and Narcisse and to hear Introductions 620, 623, 825, 895, and 1248, as well as Resolutions 294, 395, and 791. Earlier this month, I joined the Mayor and Commissioner Vossen to announce Healthy NYC, a new campaign to increase New Yorkers' life expectancy by 2030. My bill, Introduction 1248, which we are hearing today, seeks to codify Healthy NYC and would require the Department of Health and Mental Hygiene to develop a 5-year population health agenda to improve public health outcomes, address health disparities, and improve quality of and access to health care. I want to thank Commissioner Vossen for being here today to discuss this critical initiative. Healthy NYC ties into our hearing topic because despite improvements in life expectancy among people with HIV, thanks to effective antiretroviral therapy, these improvements have not been equal across age, sex, racial, and ethnic groups. The gap in life expectancy between people with HIV and the general population has narrowed but still remains. I look forward to supporting this vital work and working with the Commissioner and DOHMH to create a healthier New York City for all. According to DOHMH's latest HIV surveillance report, there were almost 23,000 adults aged 50 and older living with diagnosed HIV in New York City as of December 2021, representing 65% of all people living with diagnosed HIV in the city. Although the COVID-19 pandemic impacted the provision of HIV testing, diagnosis, and treatment, we must not forget about those who are most vulnerable and continuing to battle this virus. The joint hearing held in 2006 was titled Older Adults and HIV, Tailoring City Services to Help the Senior Population Face the Prospect of Growing Old with HIV. 17 years later, New Yorkers are no longer just facing the prospect of growing old with HIV. That experience is here and is very real. The reality is that older adults are often overlooked or neglected by the healthcare system and society, and older adults with HIV may face additional barriers to accessing and staying in HIV care, such as lack of insurance, transportation, or social support. They may experience stigma, discrimination, or isolation from their families, communities, or healthcare providers because of their HIV status or age. But it is important to remember that older adults with HIV are valuable and resilient members of our society. They have lived through many hardships and changes in the history of the HIV epidemic that we cannot even fathom. These individuals have valuable knowledge, experience, and wisdom to share with others. But right now, many are uninsured or underinsured and may face difficulty affording the medications, copays, deductibles, and other health care costs, as well as discrimination or stigma from insurance providers or employers because of their HIV status and age. In addition, some older adults with HIV may have limited income or resources to pay for their HIV care and treatment, as well as other expenses such as housing, food, transportation, or utilities. They also have to deal with complex benefit systems or eligibility requirements that can be confusing or overwhelming. Older adults with HIV are more likely to have other chronic conditions such as diabetes, hypertension, cardiovascular disease, cancer, or osteoporosis, which can complicate HIV management and increase their risk of complications or death. They may also have cognitive impairment, dementia, or neurocognitive disorders that can affect memory, concentration, or decision-making abilities. That is why they cannot be forgotten or left behind in our continuing efforts to eradicate the HIV/AIDS epidemic from New York. These are just some of the issues that older adults with HIV face in New York City. As chair of the Committee on Health, I am committed to ensuring that the city is providing comprehensive and culturally competent services and programs that address the needs of this population. In conclusion, older adults with HIV are a vital and valuable part of our city's diverse population. They deserve our respect, recognition, and support, as well as a city budget that reflects a commitment to improving older adults with HIV health outcomes. I have dedicated my personal and professional life to healthcare advocacy and advocacy for the LGBTQIA+ community, particularly as a former staff member at Gay Men's Health Crisis, where I personally witnessed the devastating effects of HIV and AIDS with our clients, many of whom were older adults. Healthcare is a human right, and a person's sexuality, gender identity, or HIV status should not determine the quality of care they receive. I want to conclude by thanking the committee staff for their work on this hearing, committee counsels Sarah Stucci and Chris Pepe, and policy analyst Manor Butt, as well as my team, Chief of Staff Jonathan Boucher, Legislative Director Kevin McAleer, and my legislative fellow Andrew Davis. I will now turn it over to Chair Narcisse for her opening statement. Thank you.
Good morning. I'm Council Member Mercedes Narcisse, Chair of New York City Council Committee on Hospitals, and a proud representative of the 46th Council District in Brooklyn. Before we begin, I want to extend my thanks to Chair Crystal Hudson and Chair Lynn Schulman, as well as all the staff for the collaborative work that has been done on the issues we will be discussing this morning. Today, we are here to discuss on a specific group of people living with HIV. Those who are 50 years or older. This group represents more than half of all New Yorkers living with diagnosed HIV. Older adults living with HIV are not just survivors, they are advocates and leaders that have dedicated their lives to the betterment of our communities. They have lived through the darkest days of the epidemic, when there was little hope and no effective treatment. They have also witnessed the tremendous advances in science and medicine that have transformed HIV from a death sentence to a chronic condition that can be managed with medication. My own journey in healthcare has deeply connected me to this cause. As a registered nurse with over 30 years of experience, I was one of the first nurses at Elmhurst Hospital to volunteer to care for patients with HIV. This experience during a time when fear and misunderstanding of the disease were rampant. shaped my approach to healthcare and advocacy. Working with the visiting nurse services, I also had the opportunity to deliver care to homebound HIV patients, seeing firsthand the challenges they face in their daily lives. However, older adults living with HIV face unique challenges that require our immediate attention and action. Studies have shown that they are more likely to experience multiple chronic conditions, such as diabetes, heart disease, and cancer, that can complicate their HIV care and affect their quality of life. They are also more likely to experience social isolation, depression, and poverty, which can undermine their mental health and well-being. They may face barriers to accessing healthcare and social services that are tailored to their needs and preferences. And they may encounter stigma and discrimination from healthcare providers, family members, and society at large, based on their age, HIV status, sexual orientation, gender identity, race, ethnicity, or immigration status. In understanding the deeply painful history of prejudice, it is imperative to note that just over 3 decades ago, in 1990, tens of thousands of Haitians marched across the Brooklyn Bridge to protest the U.S. government characterization of Haitians as at-risk factor for AIDS. This demonstration was against an FDA recommendation that sought to exclude all people from Haiti or the sub-Saharan region from donating blood, despite the fact that Haitian New Yorkers were no more likely to carry the AIDS virus than any other group. Discriminatory FDA recommendation was eventually reversed 4 days after the historic march, showcasing the pervasive prejudicial bias that unfairly targeting certain communities, echoing the stigma that until recently prevented gay men from donating blood. This historic context highlights the importance of understanding the existing biases in our healthcare and the urgency of promoting regular HIV testing among older adults who are often overlooked. It is crucial to acknowledge that many older adults and their providers do not perceive the aging population as being at risk for HIV or may be unaware of the current testing guidelines. Consequently, a significant number of older adults are diagnosed late in the course of their infection, when AIDS or other serious complications have already developed. Data published in 2015 revealed that only 36% of adults aged of 50 to 64 in the United States reported ever being tested for HIV. Wow. Lower figure compared to the 53% reported by adults aged of 18 to 49 in New York City. Merely 29% of adults aged 50 to 64 reported undergoing HIV testing in 2018. Educational efforts to inform older adults about the importance of understanding their HIV status and undergoing regular testing are crucial in ensuring their health and the quality of life. We must strive to create easier, more accessible, culturally sensitive, and confidential HIV testing opportunities tailored to older adults and their unique needs while connecting them to appropriate care and prevention services. Undoubtedly, today's discussion on older adults living with HIV is a valuable step forward in our city's effort to make HIV information, prevention, and treatment more readily available for New Yorkers. I look forward to hearing the testimony of all the witnesses who are joining us today, and I'm hopeful that we can take everyone's perspective into consideration as we continue our work on Intros 620, 623, 825, 895, 1248, and Resolution 294, 395, and 791. In closing, I extend my heartfelt gratitude to all that have gathered here to share their invaluable perspective and insight today. And I want to share something with you. In 2000, I got stuck with the needles where I thought I was going to die. And that gave me open eye and what an HIV patient can go through. So, well, everybody was scared coming and talk to me and wondering if I was gonna die, but I was persistent and I took the medication for 2 weeks. In that 2 weeks, I got so scared, I had to do the test almost every month. I would be standing behind the door to take my test to see if I was HIV. Thank God I was not, but that gave me a new look into caring for a patient with HIV. It was not easy. I would also like to thank the Hospitals Committee Council, where Agazoanwa, I don't want to much of a name, and policy analyst Mano Butt, along with the Health and Aging Committee staff for their work on this hearing. Together, we can foster an environment in New York City that uplifts and supports older adults living with HIV, making our city a beacon of inclusivity and compassion and empathy. With that, I will yield back to Chair Hudson.
Thank you, Chair. I'd like to acknowledge that we've been joined by Council Members Lee and Gutierrez, and I will now turn it over to Councilmember Ossé to deliver a statement on his legislation being considered today, Introduction 825.
Thank you, Chairs Hudson, Narcisse, and Schulman for this hearing. If you look up at this dais, there are 2 LGBTQIA identified chairs of this committee, as well as a Haitian woman who are holding this important oversight committee hearing. You know, this policy and this oversight is personal to, I'm guessing, the 3 of you sitting up there, as well as myself. Today, we are hearing my bill, Intro 825, a bill requiring DOHMH to report on the city's outreach and distribution efforts to ensure New Yorkers have access to pre-exposure prophylaxis, or PrEP. PrEP is a medication that prevents HIV, and it is crucial to ensure that as many New Yorkers have access to it, and we need the data and information to do this. Under Intro 825, we will have data and information on whether our city's efforts to promote access to PrEP are truly equitable and accessible. Powerful medical technologies have allowed us to make incredible strides in the field of healthcare, most especially within HIV and AIDS. But far too often, these gains are not enjoyed by everyone. It is often Black and brown, working class, and older New Yorkers who are often marginalized and left out of the conversations when it comes to access to healthcare. As an elected official, we have a responsibility to extend the blessings of modern medicine and close the gap. This bill will equip us with the tools necessary to access the problem before us and work to solve it. Any resource available to address HIV/AIDS in our city must be accessible and inclusive for all. You know, I started taking PrEP last year, and in the process as an elected official that I consider myself capable of figuring things out on my own, was very difficult, you know, to find if my healthcare would allow me to use PrEP. It was just an incredibly confusing process that I know so many of my friends have undergone and so many New Yorkers deal with, in tangent with the stigma around testing and HIV/AIDS as a whole. It is a real setback for a lot of people in accessing this important medicine. So I'm proud to have a hearing on Intro 825 today and look forward to its swift passage and implementation. Thank you very much.
Thank you so much, Councilmember. I'll now turn it over to Councilmember Sanchez to deliver a statement on her legislation being considered today, Introduction 895. But before that, I also want to recognize that we've been joined by Councilmember Brooks Powers.
Thank you, chairs, and thank you to all of my colleagues who are here and for the administration's presence at this important hearing. Okay, sorry, I said what I didn't mean to say. Okay. Despite significant strides in fighting the HIV epidemic, pernicious inequities persist in rates of HIV and STIs across our state, concentrated in Black and brown communities. The Bronx has over 23,500 people living with HIV. This is over 3 times higher than the overall New York State rate, and the highest within New York City, with rates more than double than our siblings over in Brooklyn and Queens and Staten Island. In 2021, the Bronx also had the highest rates of HIV/AIDS death. These rates are most alarming among Black non-Hispanic Bronxites, who are diagnosed with HIV at over twice the rate of their white and Hispanic neighbors, and experience the majority of deaths in our borough. In honor of Trans Remembrance Week this week, I also uplift the particular inequities facing our trans siblings, which are even more stark. Trans feminine people are 66 times more likely than the general population to receive an HIV diagnosis. Trans masculine people, 7 times more likely. And these inequities are a problem of caring for our older adults. As has been said, approximately 60% of people living with HIV in the US are now over 50 years old. And that number is expected to rise to 70% by 2030. That is why I am so proud to be in these chambers with Chair Hudson, Chair Shulman, and Chair Narcisse. In recognition that testing is awareness and awareness can be prevention, I am proud to be sponsoring Intro 895, which would require the Department of Health and Mental Hygiene to establish more quickie labs in the city, providing rapid same-day testing services for HIV and some sexually transmitted infections. And it would launch an information and awareness campaign on their services. This bill, spurred from organizing efforts by many of the advocates here in the room today, is an acknowledgement that the services that DOHMH currently has can work, but we need more. I look forward to hearing the administration's response and moving forward to ensure that we can provide these essential services while breaking down stigma, with a particular focus on increasing access to testing for those facing the highest rates of STIs. If the chairs would permit me, I just want to thank the advocates who have been working so diligently with all of us and have brought us to this day. Callan Lord, Vocal New York, MHHC, Latino Commission on AIDS, Housing Works, Health People, St. Anne's Harm Reduction, the New York City Anti-Violence Project, African Services Community, Caribbean Equality Project, Black Health, Harlem Pride, Ali Forney Center, Destination Tomorrow, and in my team, our communications and legislation director, Kadeem Robinson. Thank you so much. Thanks to my colleagues who are already on this piece of legislation, and I hope that we can push for swift passage. Thank you.
Thank you so much, Councilmember. I'll now turn it over to Councilmember Marte to deliver a statement on his legislation being considered today, Introduction 623, though I'd also like to recognize that we've been joined by Councilmember Joseph.
Good morning, everyone. First of all, I'd like to thank Chair Hudson, Shulman, and Narcisse for holding this hearing, and Chris Pepe and Chloe Rivera from the Aging Committee for working with us these past couple of months to make this happen. I'm here today to discuss Intro 623, which would require senior services provider to attend anti-discrimination training on sexual orientation, gender identity, and expression. This will help our senior centers become safer and more welcoming spaces for LGBTQIA seniors. It's hard enough being a senior in New York. It's even harder being an LGBTQIA senior in the city. These seniors are more likely to be low income, have chronic diseases or disabilities, and experience depression and social isolation. This is the community that needs senior center most. But even with hundreds of senior centers citywide, nearly 60% of LGBTQIA older adults report feeling the lack of compassion, with over half feeling isolated from others. And if they try to take advantage of senior centers, they risk facing discrimination and harassment. For a city that claims to be a safe for seniors and a supportive one, accepting homes for this community, this is unacceptable. When almost 90% of LGBTQIA seniors in New York say that they would feel more comfortable with service providers who are trained in these practices, it is our job as elected officials to listen to them and make sure that the providers have this training. This bill should have been passed decades ago, but I'm thankful of my 35 colleagues on the council who have recognized this failure and who have co-sponsored this bill so we can finally pass it and stop the discrimination against our seniors. Thank you.
Thank you so much, Council Member. I'd like to also acknowledge that Councilmember Barron is with us online. And before we begin with today's oversight topic, we're going to hear from Dr. Ashwin Vasan, the Commissioner of Health, for his remarks on Healthy NYC and Introduction 1248 by Chair Shulman. Once we've heard from the Commissioner, we will allow any questions on his testimony and on Intro 1248, and then we'll allow the Commissioner to leave, and we'll proceed with testimony focusing on today's oversight topic by Dr. Celia Quinn from DOHMH. I'll now turn it over to the Committee Counsel to administer the oath.
Please raise your right hand. Do you swear to tell the truth and the whole truth and to respond honestly to council member questions?
Yes.
You may proceed, Commissioner.
Thank you. Good morning, everyone. Good morning, Chair Shulman, Hudson, Narcisse, and members of all the committees. I am Dr. Ashwin Vasan, New York City Health Commissioner. I'm joined by Dr. Celia Quinn, Deputy Commissioner for Disease Control, who will speak later on the oversight topic, older adults living with HIV and the related legislation. Thanks to advancements in HIV screening, treatment, and prevention, as well as institutional and community efforts to reach the last mile and address inequities, we have a clear opportunity in our lifetimes to end the HIV epidemic in New York City. Dr. Quinn will speak to our work in this regard. Before the advent of and widespread access to HIV medications, HIV/AIDS was a leading cause of death in New York City until the early 2000s. The dramatic gains in life expectancy experienced in the first decade of this century are, in part, due to the introduction and widespread access of antiretroviral therapy, which transformed HIV from a fatal diagnosis to a chronic disease. I began my own career working to ensure access to HIV treatment around the world and to address this leading cause of preventable death. And so I'm very glad as well, and I want to thank Chair Schulman for the opportunity to testify today on Healthy NYC, the city's campaign to improve life expectancy and to create a healthier city for all. The health of New Yorkers is certainly at a major inflection point. As we emerge from the COVID-19 pandemic, New Yorkers are, on average, sicker and dying too soon. Life expectancy, the average number of years a person can expect to live from the time of their birth, dropped more than 4.5 years, from 82.6 years in 2019, the highest ever recorded life expectancy in New York City, to 78 years in 2020. Underneath these overall data, we also see stunning inequities, reflecting that our health challenges are not experienced equally. Black New Yorkers, starting from the lowest baseline life expectancy in 2019 of 77 years, lost 5.5 years in 2020, and Latino New Yorkers 6 years. Overall, this is the biggest and fastest drop in lifespan in a century. In 2021, life expectancy rebounded slightly to 80.7 years, accounting for the lessening impact of COVID-19 due to advances in treatment and our vaccination and prevention efforts. However, we are still 2 years behind in lifespan from where we were in 2019. And there should be no expectation that we will just return to our previous baseline or meet our common expectation of healthier, longer lives without intentional action. 2 weeks ago, Chair Schulman joined myself and the mayor as we launched Healthy NYC, the city's population health agenda to improve life expectancy and create a healthier city for all. Healthy NYC sets, as a matter of civic planning and civic expectation, that all New Yorkers, year after year, should expect to live healthier and longer in our great city. And it is a plan that demonstrates how the city of New York is stepping up to meet this challenge, along with partners across sectors. We know that health is a choice, but it's not just an individual choice. It's an institutional choice, and it's a democratic choice. And that's why we have government to tackle those institutional and democratic problems that are too big or too complex for us to address on our own. Healthy NYC sets clear mortality reduction goals to reduce, number one, the greatest drivers of overall risk and death. Number two, premature death below age 65, which predominantly impacts Black and Latino New Yorkers. Number three, excess deaths, which predominantly impact vulnerable groups like older New Yorkers we're discussing today, disabled people, people with underlying health conditions or living in vulnerable settings. And number four, the most extreme racial inequities, including unacceptable rates of Black maternal mortality. The Healthy NYC goals set numeric targets for reducing deaths from chronic and diet-related diseases, screenable cancers, overdoses, suicide, Black maternal mortality, violence, and COVID-19. These are all the leading causes of death in our vital registry. By 2030, if we are successful in achieving these disease targets, we will reach the highest ever recorded life expectancy in New York City, 83 years. And we will stop thousands of preventable deaths. We want New Yorkers to experience more birthdays, more weddings, and more graduations, more holidays. And as we're entering the holidays, that's even more more trenchant, more holy days, more life lived. And to do so is an all hands on deck moment. It's a civic responsibility, and we must engage all parts of our civic infrastructure to achieve it. Government, through Healthy NYC, can set the guideposts and the goals, and will indeed play a big part in achieving these goals. But we will need nonprofits, community organizations, the private sector, and everyday New Yorkers to align around these goals. Healthy NYC is how we ensure everyone across sectors, across our city, consider health in every institutional and individual decision they take. It's how we link all of these decisions to perhaps the most important single metric we have for a society and for our democracy, how well and how long we live. So I'm happy that we have the support and partnership of the City Council in this campaign. The Health Department proudly supports Introduction 1248, which will require our agency to lead the development of a citywide population health agenda that focuses on improving life expectancy. The bill also requires that we report on progress towards achieving the goals set in that agenda and update the agenda every 5 years, setting new goals to achieve new life expectancy targets as needed. Under the legislation, the Health Department will consult with stakeholders and provide regular updates to the City Council on progress made. This bill ensures that planning around health and life expectancy as the key measure of our collective health will be a permanent feature and a legacy in New York City government, one that lasts from mayor to mayor and administration to administration, and city council to city council. Because we know that this is long work, it is hard work, and it is bigger than the ability of any one institution or any one branch of government or any one community to achieve on their own. Improving life expectancy will require collaboration, energy, and focus from many partners across the 5 boroughs. Healthy NYC will not only be a model for civic planning for health for our city, but for our nation, showing once again that New York City is a leader and innovator in public health. Thanks to the Council, the Speaker, and specifically to Chair Schulman, Healthy NYC will be an organizing force in our government for years to come. Thank you once again for the opportunity to be here today. I look forward to answering your questions on Healthy NYC and on Intro 1248, and I will then turn things over to Dr. Quinn for the remainder of testimony.
Thank you so much, Commissioner. I'll now turn it over to Councilmember Schulman for any questions.
Hi, Commissioner. Thank you very much. And this is a much-needed program. So do you know when we'll have an agenda ready and just do you have a timetable?
So Healthy NYC lays out mortality targets and lays out bundles of strategies to get there. One great example is the bill that we will be together signing later today, the Sweet Truth Act, to require added sugar labeling on all New York City restaurants and food cellar establishments. So as we've outlined those bundles of strategies, we also link those to our plans, our mental health plan. We're working on a chronic disease prevention plan and diabetes prevention plan, as you passed a law earlier this year on that front. So we expect that we will be reporting annually on progress towards these goals, but all of the KPIs, the metrics, the accountability measurements are built into these citywide health plans that we have laid out throughout the 2 years of this administration.
And then I know you spoke a little bit about it, where HIV comes into that whole plan in terms of increased life expectancy.
Well, I'm so grateful that HIV is no longer a leading cause of death in this city due to antiretroviral therapy. But you rightfully point out there are still deep inequities. And so just because Healthy NYC focuses on the leading causes of death primarily doesn't mean our work, and you will hear much about this work later in testimony, to go to that last mile and to end the HIV epidemic doesn't remain central to the mission of the Health Department in New York City.
And my recollection from the conversations that we've had about Healthy NYC is that you'll be going out into different communities throughout the city to talk with constituents and talk with various stakeholders. Is that correct?
That is absolutely correct, 100%. We have already begun that work. We have meetings scheduled in every borough with different stakeholder groups, whether they be community partners, faith-based organizations, the private sector, hospital systems, payers, This is an all-hands-on-deck strategy. There will be a campaign as well in early 2024 targeting everyday New Yorkers as well, because we do not want this to feel simply like top-down government and top-down institutional policy. Everyday people have to be involved in Healthy NYC too.
And I want to just make sure, I know we've had this conversation, but just to state it here publicly, is that you'll be reaching out to the council members as well to talk to them about their various constituencies and their districts.
100%.
Okay, thank you.
Any other questions from colleagues?
Number 18. There's concerning number of older people being diagnosed currently with HIV and AIDS, or advanced disease, we may say. What efforts are being made to prevent this from happening?
I'm happy to defer questions about the oversight topic to Dr. Quinn later on. Happy to focus my answers on Healthy NYC today, but I know that Dr. Quinn can respond to your question. We can do that now or later, as you wish.
We'll do it later when we get there.
Okay.
Thank you so much, Commissioner Vossen. I think we'll close that out.
Okay.
Thank you
very much.
I'll now turn it over to Councilmember Brewer to deliver a statement on her legislation being considered today, Resolution 791.
Thank you very much, Chairs Hudson, Schulman, and Narcisse. This particular resolution, 791, calls on the state and the governor, the legislature and the governor, to pass S2960A5741, and the Senate sponsor is Brian Kavanaugh. It provides an annual adjustment of the maximum income threshold eligibility for SCREE, DREE, SHE, and DHE by any increase in the CPI, the Consumer Price Index, same way that Social Security increases take place. In 2020, there were a total of 71,665 households receiving SCREE or DREE benefits in New York City. And we know that with continued increases in their Social Security benefits, which we hope take place, those once eligible households can quickly become ineligible. With this resolution, older adults and people with disabilities could both see an increase in their Social Security benefits and keep their affordable housing. I think we know that Social Security benefits increased by 5.9% in 2020, 8.7% in 2023, and in 2024, another 71 million Americans, which is a good thing. But with this added income, these increased Social Security benefits place many older adults and people with disabilities at risk of losing their housing benefits, because SCREE, DREE, SHE, and DHE income thresholds do not increase at the same rate. That's why we need this resolution. Thank you for including it. I certainly want to thank Holly Chu from the office of Brian Kavanaugh in the State Senate, and Cynthia Hornig from my office, and thank you very much.
Thank you so much, Councilmember Brewer. I'd also like to acknowledge that we've been joined by Councilmember Mealy. And now I'd like to turn it over to Dr. Quinn for her testimony.
Thank you. Good morning, Chairs Hudson, Schulman, and Narcisse, and all members of the Committees on Aging, Health, and Hospitals. I also want to thank Commissioner Vossen for speaking today on Healthy NYC. My name is Dr. Celia Quinn, and I'm the Deputy Commissioner for the Division of Disease Control at the New York City Department of Health and Mental Hygiene. I'm pleased to be here with my colleagues, Dr. Emma Kaplan-Lewis from New York City Health and Hospitals, and Jocelyn Groden and Anya Harasme from the New York City Department with HIV and the legislation included on today's agenda. Before I describe the Health Department's specific programming and services for older people with HIV, I want to mention the advances in HIV treatment that have allowed people with HIV to live longer. HIV antiretroviral medicines are safer and more effective than ever. When taken as prescribed, HIV treatment medicines can reduce the amount of virus in the body to levels so low that the virus is undetectable. People with undetectable HIV cannot pass HIV to others through sex. In New York State, HIV treatment is available to anyone who has HIV, regardless of immigration status. As more people with HIV are on treatment and have access to health insurance and patient assistance programs, they are living healthier, longer lives. In 2021, there were approximately 49,400 people ages 50 years and older with diagnosed HIV in New York City, representing 56% of all people with diagnosed HIV in the city. Among people 50 years and older with HIV, 90% were receiving care, 86% were prescribed HIV treatment medicines, and 83% were virally suppressed, meaning that the amount of virus detectable in the person's blood is very low. The Health Department receives federal funding through the Ryan White HIV/AIDS program to support the medical and non-medical needs of income-eligible people with HIV in New York City. In 2021, approximately 48% of Ryan White clients were ages 50 years and older, and 93% of those receiving Ryan White-funded HIV medical care were virally suppressed. This speaks to the Ryan White program's role as a critical safety net provider for people with HIV who are uninsured or underinsured. Clients benefit from client-centered care coordination and a range of supportive services, including food and nutrition services, mental health services, housing placement and short-term rental assistance, health education, and legal services, among others. The Health Department continues to work closely with our HIV Health and Human Services Planning Council of New York to set program priorities and allocate resources for Ryan White clients. New York City is also seeing decreases in the number of older people newly diagnosed with HIV. In 2021, 273 people ages 50 years and older were newly diagnosed with HIV, which is down 21% since 2017 and 67% since 2001, when HIV reporting began in New York State. The sooner people with HIV are diagnosed, the sooner they can be connected to HIV care and treatment. We're encouraged that the federal government is moving towards requiring Medicare to fully cover HIV pre-exposure prophylaxis, or PrEP, including long-acting injectable PrEP, and look forward to more information from them on this initiative. We also welcome the final rule issued by the federal government for Medicare to reimburse providers for community health worker services, including principal illness navigation services for those with HIV/AIDS, which will start in January 2024. This rule will provide resources for care coordination, patient education, facilitation of social services, and health systems navigation for older adults with HIV. In addition to our work to ensure that more New Yorkers know their HIV status, the Health Department oversees an array of programming and services for older people with HIV. Our Building Equity Intervening Together for Health, or Be Into Health initiative, funds 9 HIV clinics across the city to implement evidence-informed HIV care models that support communities most affected by HIV, including 3 clinics that specifically focus on serving Black and Latino people with HIV who are ages 50 years and older. Be Into Health's goals include increasing engagement and re-engagement in HIV care and decreasing racial and ethnic inequities in HIV outcomes. Since Be Into Health's launch in 2021, funded clinics have served 267 Black and Latino people with HIV ages 50 years and older. In April of this year, the Health Department launched a new Ryan White program for older people with HIV, which funds 3 New York City health and hospital sites to deliver outpatient health services designed to treat the complex needs of older people with HIV. Services include medical history taking, physical examination, diagnostic testing, treatment and management of physical and behavioral health conditions, preventive care and screening, prescription management and treatment adherence, education and counseling on health and prevention issues, and referral to specialty care and other services. Providers also offer social and physical activities addressing isolation among older people with HIV. And my colleague, Dr. Koppelin, can answer more questions about this specific program. Last year, the Health Department also launched our PlaySure Network 2.0, which is a network of 18 organizations funded to provide a comprehensive health package of HIV-related services in healthcare and non-healthcare settings. And this uses an equity-focused one-stop shop and holistic client-centered model. PlaySure Network 2.0 providers offer universal HIV testing, PrEP and emergency post-exposure prophylaxis, or PEP, immediate initiation of HIV antiretroviral treatment, sexually transmitted infection, or STI, testing and treatment, outreach and navigation services, and mental health, substance use, and other supportive services. Several funded organizations offer programming and services designed for older people with HIV. For example, Exponents offers Arrive, an 8-week education and counseling program for older people with HIV who are struggling with addiction. GMHC's Healthy Aging Project and its Hub for Long-Term Survivors offer workshops, resources, and referrals to supportive services. and GMHC's Thriving at 50 group for older Black and Latino people with HIV focuses on reducing social isolation, depression, and stigma. And New York Presbyterian's Comprehensive Health Program offers a wellness program for people with HIV who are 50 years and older. Last year, the Health Department's Training and Technical Assistance Program launched a training for clinical, non-clinical, and social service providers on enhancing health outcomes for older people with HIV. Participants learn how these clients' unique mental and physical health needs may impact their care, treatment, and health outcomes. Participants learn about the importance of using a strengths-based health equity approach and how to transform HIV care settings to better serve older clients with HIV. Since the training launched last February, we have held 7 trainings attended by a total of 112 participants. The Health Department's NYC Condom Availability Program delivers condom education trainings at senior centers across the city. And since last April, we have conducted over 17 trainings at senior centers attended by a total of 544 participants. I'm happy to be here today with the Department for the Aging, which has a broad range of programs serving older adults with HIV. For a quick description, NYC Aging serves older New Yorkers 60 and over through a range of programs and services, including older adult centers, case management, home-delivered meals, mental health programs, workforce development and supports, and a host of other aging services. All older adults who are physically able are welcome to attend any of the more than 300 older adult centers across the city to participate in programs and activities or receive services, including a daily congregate meal, referrals, and case assistance. Additionally, homebound older adults may be eligible to receive home-based services, such as case management, home-delivered meals, home care, friendly visiting, and more. Before we answer your questions, I'd like to briefly discuss the legislation being heard today. Regarding Introduction 825, which relates to reporting on PrEP outreach and distribution, New York State Department of Health regularly reports on the outreach and distribution of PrEP. They purchase statewide PrEP prescription data and other HIV-related data that are uploaded to the Ending the Epidemic, or ETE, dashboard annually. The New York State ETE dashboard can be filtered by region and by sex, age, and race ethnicity. Data on the number of people with PrEP prescriptions in New York City are already publicly available on the ETE dashboard. The Health Department uses these data to inform our efforts to expand access to PrEP and increase PrEP uptake among specific groups and communities. Requiring the Health Department to report on this data would duplicate the state's current efforts. Regarding Introduction 895, which relates to providing rapid testing for STIs in all boroughs, the Health Department has concerns related to the logistics and feasibility of the proposed legislation as written. The Health Department operates sexual health clinics across the city, all of which offer rapid HIV testing. 2 clinics, Chelsea and Fort Greene, offer Quickie Express visits for rapid STI testing for people who do not have symptoms, with most HIV, chlamydia, and gonorrhea test results available within hours. We are able to process the chlamydia and gonorrhea tests through the use of a special specimen testing machine that is located on site. These machines are large, stationary, and require specific infrastructure to operate. Our other clinics also offer rapid HIV testing and screening and testing for STIs with immediate treatment initiation if indicated. In addition, the Health Department partners with approximately 70 organizations located in all 5 boroughs to deliver free HIV self-tests directly to New Yorkers at home. And as I mentioned earlier, the Health Department funds numerous organizations across the city to offer routine STI and HIV testing, including rapid HIV testing, in clinical and non-clinical settings. The department distributes resources and support services based on need, taking into account a variety of factors, including our surveillance data, care access, and equity concerns. Neighborhoods and communities with the highest burden of STIs can change quickly. Additionally, the burden of different STIs can vary by population within neighborhoods, at times requiring targeted approaches by gender, race and ethnicity, age group, or geography. Given the constraints around the method of testing and the infrastructure needed to perform these tests, we do not support this legislation. Introduction 620 relates to mpox education and prevention efforts and an infectious disease vaccine scheduling portal. The Health Department has incorporated mpox prevention activities into our routine sexual health programming. This includes provider education, assisting providers with access to mpox vaccination, and partner and community outreach, including during Pride events. The Health Department provides a list of mpox vaccination sites on the city's vaccinefinder.nyc.gov website, which includes links to the various sites for scheduling and other information. The infectious disease vaccine scheduling portal described in this legislation would take a substantial amount of time and resources, considering the lack of standardization across healthcare provider platforms. We are pleased to report that the number of mpox cases in New York City has remained low in 2023, with just 22 cases reported from October 8th through November 4th of 2023, and a total of only 133 cases since January 1st, 2023. In our view, existing vaccine information and resources are effective and meet the current level of need. The Health Department remains committed to providing comprehensive services and support to older adults living with HIV, and we're happy to discuss with the Council how we can best support the intention of the proposed legislation. Thank you for the opportunity to be here today to address this important topic, and we look forward to answering your questions.
Thank you so much. I asked Councilmember Brewer to read her statement earlier, but I just want to formally acknowledge her presence with us today. And we'll jump to questions, if that's okay. The first of which is, what outreach is being done to connect older adults with HIV to services to reduce loneliness and isolation?
Sure, so thank you for raising the issue of loneliness and isolation for older adults. I'd like to turn it to the Department of the Aging to answer that question.
Good morning. I'm Jocelyn Groden, Associate Commissioner with New York City Aging, and joined by my colleague, Anya. With our overarching mission to ensure that New York City is an inclusive place to age in place, New York City Aging has a variety of services that Dr. Quinn mentioned to support older adults and breeding and creating community and addressing social isolation. Some of our many programs include over 300 older adult centers located throughout the city, our workforce programs, mental health, home-delivered meals. As Dr. Quinn mentioned, we also have particular programs for largely homebound older adults, which includes case management, home care, home-delivered meals, and friendly visiting. And programs like Friendly Visiting, which is a volunteer match program, as well as our mental health programs, provide very specific spaces to combat particular struggles around social isolation, as well, again, as older adult centers as an opportunity to connect with people in your community, participate in classes, and be connected.
Thank you. And my apologies, I want to acknowledge Councilmember Rivera, who has also joined the hearing. Have steps been taken to ensure that older adult center staff are HIV competent and can foster HIV stigma-free environments?
So good morning. So within our OAC network, there is at least one center in each borough that specializes in LGBTQIA+ older adult services. These centers include the Edie Windsor Sage Center Harlem, Sage Center Bronx at Cortona Park Pride House, Sage Center Brooklyn at Stonewall House, Sage Pride Center of Staten Island, and the Queens Community House Center for Gay Seniors. While not all older adults living with HIV are part of the LGBTQI+ community, all of our OACs are obligated to serve the needs of their local community, including those living with HIV. Our providers are uniquely positioned to identify and provide the specific types of supports and services which best fit the needs of their center members and local older adults. Additionally, culturally specific programs, meals, language access, and activities are a key component of our network of services. Our network of OACs, home-delivered meals providers, naturally occurring retirement communities, and other services are required by their contracts to be culturally specific in their programming. While we recognize that not all older adults living with HIV are part of this community, there are overlapping needs within them. That's why OACs geared towards the LGBTQIA+ community may have support services for older adults living with HIV. Moreover, those centers work to break down stigma associated with queer life and provide affirming programs which are specific to that community.
Thank you. I'll take that as a yes. Have there been any efforts to create a working group of aging services providers and HIV services providers to identify opportunities for collaboration sharing of resources, and best practices?
Thank you for the question. For the past year, New York City Aging has been working with 23 other city agencies as part of our Cabinet for Older New Yorkers. Through this cabinet, we address a range of topics through subcommittees designed to address a variety of issues facing older adults. The Health Subcommittee includes representatives from our partners at DOHMH, Health and Hospitals, and New York City Aging has worked to educate city employees on older adult needs in healthcare situations. The Cabinet for Older New Yorkers allows for collaborative discussions between agencies to break down communication silos and use existing resources to solve problems older adults experience when interacting with city agencies. We're very excited about the work that has been completed and look forward to continuing this great work as part of our phase 2, which is currently underway. While specific subcommittee project may not focus specifically on older adults living with HIV, those considerations are taken into account as we continue to evolve this work.
Okay, thank you. I have a question on ending the epidemic. The New York City Health Department's sexual health clinics provide low-cost walk-in services, including STI services, rapid chlamydia and gonorrhea testing, immunizations, behavioral health services, reproductive health services, and harm reduction services, in addition to the HIV testing and antiretroviral therapy services. Will the health department be able to provide those additional services through other means despite proposed funding cuts for the Ending the Epidemic plan?
So the health department, all of those services that we provide at our sexual health clinics, we also are funding various organizations through different streams of funding in order to make sure that we're meeting the needs of New Yorkers and continuing to advance our shared Ending the Epidemic goals that are set out in the New York City and New York State plans.
So you don't think those services will be impacted by proposed cuts?
So I can't speak specifically to proposed cuts today. I'd have to defer to colleagues at OMB. I just don't have information about those.
Okay, can NYC Aging speak to the impact of the proposed cuts on the services that you're providing specifically to older adults with HIV?
We continually work with OMB to manage our budget needs. We look forward to working collaboratively with the council in the coming year as we discuss the upcoming city budget.
Have either agency had conversations directly with OMB or expressed the need for maintained funding in order to keep these programs and services running?
So, we'll continue as the, sorry, excuse me. We'll continue to be working with our finance and program teams to continue to do our work to serve New Yorkers, including older adults living with HIV. So these are ongoing discussions.
Okay, I'm just going to state for the record that nobody can really provide a direct answer about the programs and services that might be cut based on the proposed budget cuts. So thank you. Just in the interest of time, I want to give Councilmember Sanchez an opportunity to ask a question, and then I'll resume.
Thank you so much, chairs. Really appreciate the time. I just have one question, and reading over your testimony, listening to you say it, I am very taken aback, frankly. Testing and prevention efforts are failing in the Bronx. They're failing. They are not good. They're failing Black and brown New Yorkers. We have to do better. I didn't see any acknowledgement of that in your remarks. All I see is opposition to the efforts that the council is proposing to make these things better. And so I want to understand please share a breakdown of what is the rapid testing equipment. What are the testing rates at Quickie Labs, at rapid HIV and STI screening services, and the at-home testing services that you described by borough, by race, ethnicity, age, gender identity, and sexual orientation, because we know what the outcomes are, and we know that we're not doing enough. We're not doing enough. And so you mentioned Fort Greene and Chelsea. Each of those is over an hour away from many parts of the Bronx, maybe an hour and a half away. And we have the highest rates of HIV positivity in our borough. We have to do better. So that's my question is, how can you oppose legislation that is being put forth without describing how you are tackling the wild level of disparities that we face in the city of New York?
Yeah, we certainly share Council's goal of increasing access to STI testing across the city, and particularly in communities that are most directly impacted by both HIV and the rising levels of sexually transmitted infections. I don't have all of the data that you just asked for to present today, but we can do some of that as a follow-up. To clarify what kinds of services are offered at our specific sexual health clinics, the Chelsea and Fort Greene clinics currently have express testing. Those are tests for people who are coming to our clinic with no symptoms of any sexually transmitted infection for screening. And at those sites, we're able to provide point-of-care testing, like same moment testing for HIV, and then rapid turnaround results for screening for gonorrhea and chlamydia. We also do testing for syphilis, and that's a lab-based test, so the results come back about a week later. Our other clinics, and that includes Morrisania in the Bronx, have routine sexual health clinic services, and so they're able to do point-of-care testing for HIV at those sites, as well as lab-based testing for syphilis, gonorrhea, and chlamydia with a slightly longer turnaround time. I also mentioned the at-home testing programs that we have, where we partner with a lot of organizations to make sure that people have access to at-home care. And so, again, we work with a lot of community-based organizations and others to try to get information about sexual health testing out to all of New Yorkers, and we certainly welcome partnership with Council on that.
Thank you. Look forward to the numbers. I understand what the services are. I just wanted to see how they're being administered.
Thank you. In 2021, 17% of recorded new HIV diagnoses in New York City were of New Yorkers age 50 plus. These numbers are likely higher given the fact that HIV testing is not widely utilized by older adults. How does NYC Aging promote HIV testing and prevention medications like PrEP and PEP to older adults?
So our overarching mission is to ensure that we meet the needs of every older adult who walks into an OAC, calls Aging Connect, requests case management services, or needs any kind of assistance to find those resources. As we have stated within our network, there's at least one center in each borough that specializes in LGBTQIA+ older adult services, and they can access a range of supports at those centers. We do not provide direct medical care like HIV testing or prescribe medications like PrEP or PEP. However, we work closely with our partners at DOH, MH, and health and hospitals to make referrals and point older adults to the quickest way to access the care they need. My colleagues joining me here today at DOH, MH, and health and hospitals can speak more to their work in promoting HIV testing and PrEP prescriptions within the older adult community.
Okay, I'll allow them to do that.
So, like I mentioned, the health department, through a variety of different funding sources, is working with both clinical and non-clinical settings in order to make sure that there is access to HIV testing and information about PrEP and HIV services for older New Yorkers and others. One of our major programs related to that is the Play Sure Network 2.0 that I described in the testimony.
Okay, thank you. What does NYC Aging currently do to promote sexual health and wellness programming at older adult clubs?
So at New York City Aging, we work to support older adults and their range of needs, which include sexual health and wellness. We encourage centers to periodically schedule educational presentations from health experts for older adults. Additionally, many centers offer free on-site contraceptives for all genders, which are available as older adults need them. Many of those same centers offer classes or programming and wellness or sex education in differing forms based on the needs of that particular community.
Thank you. And do you know how many NYC Aging funded OACs currently provide sexual health and wellness programming, and if they're LGBTQIA+ and HIV competent?
So we are committed to serving older New Yorkers in their neighborhoods and in the specific cultural or community needs which best meet their needs. This includes LGBTQIA+ or HIV positive older adults, employees at centers who provide case assistance, oftentimes are trained social workers who are able to provide support and assistance to a range of older adults who are part of varying communities or who have specific healthcare needs. While they may not all have specialties in HIV and LGBTQIA+ needs, they are attuned to those communities and can tailor services to meet an older adult's needs. Additionally, our centers are able to develop programming which meets the needs of the populations they serve. Many centers such as RAIN, St. Gabriel's, Swinging 60s, Bay Ridge, Birkenau, and others provide sexual health and wellness programming as well as providing access to contraceptives.
And when you say they're attuned to those needs, what does that look like in terms of proactively engaging with folks who might fall into those categories?
So because we expect all of our centers to be culturally competent, assuming that they are serving, any kind of culture, right, or group, we expect that they are doing outreach to the communities. That is part of their requirements that they serve, and also just being sensitive to the needs of anybody who walks into the door.
How do you measure that?
That's a great question. So, of course, yes, our center staff are professionals, and we assess our programs annually as well. We can take complaints if there are concerns also from clients.
Okay, I'll accept that.
Thank you.
Would you commit to working with HIV service providers and aging services providers to create best practices for offering these types of programs and promoting them to older adult centers?
We have strong relationships with organizations like SAGE, which stands for Senior Action in the Gay Environment, and Griot Circle, which is an organization that provides that focuses on LGBTQI+ services for people of color. And we continually work to improve our services and programming in all of our older adult centers to best serve and support the needs of a range of older adults, including those who identify as LGBTQI+ and or are living with HIV. Our mission is always to serve the needs of older adults and meet them where they are. When they walk in the door at any older adult center or engage with any of our variety of programs in any way. We're frequently in conversations with OMB about funding for our programs and services and any new needs which might arise.
Okay, you didn't say that earlier, that you're frequently in conversation with OMB. So I hope and trust that as part of those conversations, you'll express and impress upon them the need to not cut such vital services and programming that serve our most vulnerable New Yorkers. And I know this might feel a little redundant, so bear with me, but I just want to make sure we're getting every single nugget of information from you all. Can you please describe any specific NYC aging programs and services that support older adults living with HIV?
Sure. New York City Aging provides mental health services for older adults through our Older Adult Center network and through our geriatric mental health programs. Our geriatric mental health programs are based out of 88 older adult centers throughout the city. DGMH, the shorthand for geriatric mental health, provides structured engagement sessions, assessments, and clinical services to clients who have more acute needs, for example, around social isolation, depression, anxiety, and so forth. DGMH includes mental health services that are provided by a licensed mental health clinician. Services can be individual or group-based and are provided virtually and through telephone as well as in person. We know that older adult centers who serve LGBTQI+ populations, like SAGE, which we mentioned before, also provide group therapy sessions for older adults living with HIV. The DGMH program can provide assistance for older adults who might be struggling with mental health issues related to any health issue, HIV status, or whatever they need. Lastly, it is important to note that one does not need to be a member of an older adult center in order to access our mental health programming. In other words, New Yorkers age 60 and older are welcome, and we invite them, if indicated, to access our DGMH services throughout the city.
Thank you. And you mentioned DOHMH, but are there other agencies and partners that you collaborate with to ensure greater access to preventative measures and treatment?
So as we talked about before, through our cabinet for older New Yorkers, we work very closely with DOHMH as well as health and hospitals and a range of city agencies. There are 23 altogether. At New York City Aging, we're committed to addressing older adult needs and working to connect them with the services and programs that will best support and address what they need. This can include referrals or handoffs to partner agencies like DOHMH, health and hospitals, HRA, based on the particular needs of the client. Additionally, we worked with DOHMH in the past to partner on mental health initiatives, for example, those happening in the NYCHA communities. Other opportunities to access services often overlap with other city agencies, and we work together to ensure those programs reach those who need those services. Additionally, we work to ensure that older adults who need to be connected to services from a partner agency fully understand the services that are available to them through a warm handoff that ensures a seamless connection to the services they need, as well as a follow-up to make sure that connection was appropriate and in place. We strongly urge the concept of a no wrong door approach to aging services and work to connect any older adult to appropriate programs and services, whether it's through us or our sister agencies.
Thank you. And for the doctors in the House, what initiatives are in place to address the unique healthcare needs of older adults living with HIV, such as comorbidities and age-related health conditions?
Thank you. So the programs that the health department is supporting include the Be Into Health HIV clinics, which are funded by Ryan White. Also the Placer Network 2.0 providers, which do both testing and linkage to care. And then the Ryan White program for older people with HIV, which is a newer program that started this April and funds 3 health and hospital sites to provide outpatient and ambulatory health services that are designed to treat those complex needs that you just mentioned. So I'll turn it over to Dr. Kaplan to explain more about that program.
Good morning. Thank you for the opportunity to be here today. I'm Dr. Kaplan Lewis. I'm the HIV Clinical Quality Director at New York City Health and Hospitals within the Office of Population Health. So at Health and Hospitals, we care for the entire person. We provide holistic, patient-centered HIV primary care and address many of the comorbidities that accumulate and come with aging. Some of these specific comorbidities include multiple medications, which is termed polypharmacy, cardiovascular disease, malignancy, hearing or vision difficulties, neurocognitive decline. Our providers are very tuned into these specific aging-related complications as it pertains to the adult population with HIV. As Dr. Quinn mentioned, the Ryan White funding is funding 3 of our sites in Brooklyn, the Bronx, and Queens to really redesign how HIV primary care is delivered. 60% of our patients with HIV are considered older, 50 or older. And so this is across our entire system. We're using this as an opportunity to really understand and to implement how can we redesign HIV primary care away from the earlier days of the HIV epidemic, which was more cancer and infection focused, and really towards these aging-related complications. And part of this initiative includes really, again, redesigning our care delivery, working with our partners across the city and caring for the whole patient. We are providing targeted trainings with our clinical teams to really ensure that our clinical teams are tuned in to the issues related to aging, and we're working with geriatric experts across our entire health system to implement these aging-related screenings to identify these concerns and connect patients to resources when they're identified.
Thank you. I'm now going to turn it over to Chair Schulman to ask some questions.
Thank you very much, Chair. Has DOHMH ever conducted a health needs assessment on older people with HIV and/or a needs assessment as it relates to HIV prevention?
Yes, I will. When I find the right page, I'm going to give you the entire history of needs assessment for this population. So. Most recently in 2017, the Health Department launched a New York City, New York State HIV clinics survey. This was at HIV clinics across New York City. So combining the survey results and information from site visits, the Health Department assessed clinic level factors and practices that affect viral load suppression outcomes and provided tailored clinical assistance and resources based on those findings. It included about 120 clinics and clinic networks to provide the results, distribute resources, and discuss priority areas, which included HIV and aging. And that information has helped to inform capacity building and training initiatives related to serving older people with HIV, many of which I've already described in the testimony and during the question and answer today. Following that, to develop the New York City 2020 Ending the HIV Epidemic Plan, the Health Department led a nearly one-year-long community planning process to assess the HIV and related needs of New Yorkers. So from March 2020 to January 2021, the Health Department held 9 virtual listening sessions with 308 participants and launched an online survey that garnered 619 participants in September and October 2020, and that went into the 2020 Ending the HIV Epidemic Plan. And then the Health Department also has a New York City HIV planning group that is comprised of people with HIV and people at increased risk of HIV, service providers, government officials, and community members appointed by the Health Commissioner that regularly informs our HIV prevention activities so that we have ongoing input into the work that we're doing.
Thank you. So over 70% of all people living with HIV will be over 50 by the year 2030. So what plans are being made now to expand these programs and services?
Yeah, so as we implement these services that we've been talking about, Be Into Health, the Ryan White program that Dr. Kaplan-Lewis described, our PlaySure Network 2.0, we're constantly doing program evaluation to find what's working, and that helps inform our ability to scale those up and identify the places where they're needed the most. So that's part of the way that the Health Department approaches our work in an ongoing manner.
How many sexual health clinics are currently operating citywide?
So right now, only 2 of our 8 sexual health clinics are not offering sexual health clinic services at this time, so the other 6 are offering sexual health services. The type of services that are offered at each clinic varies, and that can be found on our website.
So I know in your testimony when you talked about Introduction 895, you talked about all the different services you have at the various clinics. I don't need to go over them again, but we're hearing that with the budget cuts that are coming, that some of those clinics are going to be closed. Can you respond to that?
So we don't have plans to close the clinics right now, and those decisions would be made in the future based on what resources are available. But we recognize the importance of our sexual health clinics, both to our ending the epidemic goals and just to meeting the needs of New Yorkers.
How many DOHMH-run sexual health clinics offer access to PrEP and PEP?
So all except 1 offers access to PrEP and PEP of the ones that are open.
How many are open?
6.
Okay. What steps has the department taken to increase access to PrEP and PEP medications for older people in New York City? And are there any, a second part to that, are there any initiatives to reduce barriers to PrEP, PEP access for this community?
Yes, so of the programs that I've described so far, probably the PlaySure Network 2.0 is the one that has the most efforts in that particular area. So all 18 of those funded agencies are required to provide emergency PEP to eligible clients. As I mentioned in the testimony, 3 of the Placer Network 2.0 funded organizations are doing programs specifically directed at this population, ages 50 and older. Separately, we also support Mount Sinai to administer a PEP hotline, so that's available to anyone. And then in terms of PrEP, in addition to the availability at our sexual health clinics, we also support Ryan White providers and other providers to make access to PrEP available or connect people to care if they're not able to do that in their particular setting.
The Mount Sinai, how many do they serve?
I don't have that information in front of me.
Can
We
you get
follow
that
up.
for us? Okay, great. Get it to the committee. Do the department's sexual health clinics collect any data on the number of older adults that use such clinics to access HIV prevention and treatment services?
Yes. So as of November 13th of this year, there were 2,174 unique patients aged 50 and older who received either HIV testing or HIV medication or both at the New York City sexual health clinics between October 1st, 2022 to September 30th, 2023.
How about the PEP Excellence clinics?
So the PEP Excellence clinics are funded under Placer Network 2.0, and I don't have the utilization numbers for you, but we can follow up.
Okay, what is the current landscape of insurance coverage for PrEP?
So as I think I mentioned in the testimony, there have been recent changes. So let me find it. Okay, so currently the federal government is moving towards requiring Medicare to fully cover HIV PrEP, including long-acting injectable PrEP. So this is something we're really looking forward to hearing more about for Medicare.
Okay. The New York State Department of Health recently created an HIV Aging Project Director position within their Bureau of Community Support Services. Are there any plans to create a position like that at the New York City Department of Health and Mental Hygiene?
Sorry, Chair. Could you repeat the question?
Yes.
Yeah.
The New York State Department of Health recently created an HIV Aging Project Director position within their Bureau of Community Support Services. Are there any plans to create a position like that at the New York City Department of Health and Mental Hygiene?
Yeah, so that's the one I thought you were asking. Okay. So last year, as we started implementing the New York City 2020 Ending the HIV Epidemic Plan, we started launching internal work groups inside the health department to focus on key populations and interventions that are included in that plan to start our long-term planning on implementation. So we have an HIV and aging work group internal to the health department that has spent the last few months identifying those key activities in the 2020 and the epidemic plan that are focused on older people with HIV, assessing whether we're appropriately implementing those activities through our existing programming and services, and identifying gaps. So this work group internal to the health department is developing program proposal to address those gaps, and so that's how we're working on it internally at the moment.
Okay, so I'm going to end this line of questioning, but I just want to reiterate what Chair Hudson said about making sure that older adults, as we move forward and there's issues in terms of the budget, that these are vulnerable populations, that I want to make sure that there's real collaboration between Department of Aging and DOHMH so that there's no overlap, so that we get the programs that are essential for these individuals, that they're able to access them.
Thank you.
Thank you.
Thank you so much, Chair Schulman. And now I'm going to turn it over to Chair Narcisse for some questions.
Thank you, Chair. What mental health services are available for older adults living with HIV, and how is the city addressing the stigma and mental health challenges associated with HIV and aging?
So mental health services are an important part of the portfolio of programs that the health department supports, in particular through the Ryan White program. And I've mentioned a few of the specific Ryan White funded programs that are dedicated specifically for older adults, but all of those other Ryan White funded programs are also available to older adults, and that includes a variety of different mental health services. I'm glad that you mentioned stigma, because that's an important barrier for people seeking or receiving HIV care, and including, understanding their HIV status. So the health department's certainly been dedicated for many years to reducing stigma and discrimination against people with HIV. And that is a key component of our Ending the Epidemic strategy. And then specific to older adults, in addition to the stigma issue that you raised, and we've talked a little about this earlier, there's also just ageist attitudes and perceptions that this might not be a problem for older adults, when we know that in fact is a problem for older adults. And so that's why we've been doing some of the other programming I mentioned, like partnering with NYC Aging to make our NYC condom availability program available at senior centers and that sort of activity. I want to ask my Department for the Aging colleagues if they would like to address some of your question also.
So I don't want to repeat myself, but as I mentioned earlier, our geriatric mental health programs are available in 88 older adult centers throughout the city to provide mental health services and to support people and no matter where they're coming from, and to address stigma as we continue to fight discrimination and actively address ageism through our work.
Which other organization you partner with to do those programs?
So I don't have the full list of the programs that are funded on Ryan White. We can send that as a follow-up.
How is the city monitoring and evaluating the effectiveness of its programs and initiatives targeting at older adults living with HIV? And what improvements are being considered based on this data?
Yeah, so program evaluation is a key component of how we implement any program at the health department. And in addition to formal program evaluation methods, like I mentioned, we also work with our HIV planning group. On the Ryan White program, we work very closely with the HIV Planning Council. And so these are ways that we're constantly iterating on the work that we do and trying to improve it, make it more relevant for people in New York and those that need it.
How does H&H ensure that its HIV services are accessible and tailored to the needs of the older adults?
So our HIV clinics are all primary care medical home certified. That means that they're designed to provide comprehensive primary care beyond just HIV care and treatment. Our care model is a holistic approach that addresses HIV care in the context of comprehensive primary care. We really focus on preventing what we can, catching comorbidities early, and really treating the whole person. There's an emphasis on prevention and really a strong focus on social drivers of poor health to try and alleviate those as much as we can to ensure our patients can access excellent health care. We screen for needs at each visit to identify barriers to achieving optimal health, and we connect individuals to resources, both internal as well as external. We have a robust network of supports available across health and hospitals that improves access to specialty care that's needed by many older adults.
Thank you. Are there any unique challenges or consideration when providing HIV services to older adults, and how does H&H address them?
So one unique consideration is the aspect of polypharmacy. So that's being prescribed multiple medications. 81% of our adults are on 5 or more medications, and that's in addition to their HIV regimen. We have supports including social work support, adherence support, care coordination, case conferencing. An example from my own clinic, I have patients come in, and this can look anywhere from somebody coming in monthly and I fill their pill box for them because of their complicated regimen, or working with their home health aide and their family supports to come up with a plan that can help remind them about their medication and keep the medication straight. So those are just some examples, but we have multiple supports in place to be able to tailor it to the individual's needs.
And I have to say thank you for hearing the compliance. Like, I don't want to use the word compliance because, like I said, after I got stuck with the needles, I have to take the medication for 2 weeks, and I have learned something that I would never forget, and that make me having more empathy when I'm saying compliance. I don't want to say compliance, but for what I'm seeing, the suppressing part of it, the HIV. So I will say that we're doing a good job, and but when it comes to Black and brown communities, we're still not seeing that effectiveness of, I don't want to use, again, compliance, but the people responding to the medication better. So you have the collaboration of the AIDS in the house, HHA, and having the whole team together. I think that's the best way. And do the follow-up more often. You don't have a lax on people not returning to the clinics. And by the way, I will assume that in every H&H building you have the team working with HIV patients.
So we have 16 HIV clinics across our
16.
system in all boroughs, but at any point of entry into health and hospitals, there's potential connection, or there is the possibility of connection to services, whether it's in one of those clinics or at any entry point. And as you mentioned, we agree with the holistic team-based approach and involving the patient and their family and chosen family or biological family in the care plan to really tailor the needs to the individual, and that can look different for different people, including more frequent visits.
First, do we have them in all 5 boroughs?
4 boroughs, I'm sorry, aside from Staten Island.
Except Staten Island. So do you have, what's the number look like in Staten Island?
I don't have that answer for you now, but we can follow up.
So where the Staten Islanders, goes to get
There
services?
is a support clinic, Vanderbilt
supposed to.
is a support clinic.
All right. We are in a housing crisis. I should not be asking that question, but being a nurse in a home care nurse setting, used to serve the HIV and AIDS clients, I know how difficult it is for them to have housing issues. It is a comprehensive approach, talking about the social worker, making sure that because without a home, you cannot be compliant to your medication. You cannot even, process things. So are they getting support services through that program you were talking about too?
Absolutely. So we screen for social determinants of health at every visit, at every point of care, and involve the social worker and community health workers as well to connect patients to resources, apply for hassle-related housing or other support. And as you mentioned, if somebody is fighting for their basic needs for food, for housing, they're not going to be able to focus on their other medical issues. And so our providers are very well tuned into that and really incorporate social determinants as medical issues.
Thank you. Are there any specific outreach of awareness campaigns targeted towards older adults to promote HIV testing, prevention, and treatment still?
Sure. So I'll start by just saying we have had general broad media campaigns that are aimed at all New Yorkers, and we try to be inclusive of all gender identities, sexual orientation, race, ethnicity, and age groups whenever we do a media campaign about a health topic. Just over the summer, we had a successful campaign using fun fruit images. Hopefully people remember that one. That was reminding people to get the sexual health care services that they need, and we continue to look at different campaigns. But in addition to our media campaigns, we also have a wide network of community partners, and that we also rely on them to get the word out to our communities. And it's something we certainly would enjoy to partner with council members on.
How do you measure the success? The success that the program is working?
The success of which?
Because you say you're doing the outreach, the campaign, so how you measure that, the success of that?
Yeah, so, different metrics related to the number of people using the campaign to connect to our website to get more information, for example, like that. But in general, we're also keeping an eye on who's utilizing our services and making sure that we're targeting those appropriately.
So how many folks that actually you have in the data?
Oh, I don't have it in front of me, I'm sorry.
Can you share the data when you get it? Do you have, because if we reach, I would
could bring that as a follow-up, yeah.
Does H&H offer specialized support groups or counseling services for older adults living with HIV? If so, I think you kind of geared to that already. Provide more details about these programs. I think you already did most of them. You have anything that you want to add to it?
I can add that we have behavioral health counseling and services embedded in many of our HIV clinics and available at all of our facilities.
What partnership, collaboration, I think I asked you that too, that which partnership that you have, some of the organization, you don't have the data, you're gonna send it to us for the partnership that you're creating through the
Right.
partnership
Yeah, so
that you have.
right, so we'll be able to share the organizations that are participating as our Be Into Health campaign, the Ryan White clinics that Dr. Kaplan described, and the PlaySure Network.
Okay. Are there any specific initiatives or program within H&H that focus on raising awareness and reducing stigma around HIV in older adults? You kind of touch it, but if you want to highlight it and a little deeper, dive in it deeper for me, if you can.
Sure. So in the past, we've held a groundbreaking stigma summit that was a dialogue and is an ongoing dialogue between staff and patients to really try and bridge the understanding about how systems can be improved and to help our staff understand what the community's concerns are. Art and performance have been a part of this ongoing dialogue to give a platform for a variety of forms of expression. We have one of our team staffers who participates in weekly consumer group calls to integrate consumer voices into our regular work. We see opportunities like that, and we get a weekly update about what those concerns are. And we really try and seek opportunities like this that really take the burden off of the consumers to have to constantly be educating us about how we can evolve and improve.
Okay. How does H&H ensure that older adults living with HIV receive comprehensive health care beyond just HIV treatment? You started to. You can dive in it deeper.
So our HIV clinics are all primary care medical home certified. Our model, again, is a holistic approach that addresses HIV primary care consistent with New York State guidance. All of our patients with HIV are managed by an HIV specialist who also does their primary care, so it's not siloed HIV care with other medical care. It's all within one setting.
Okay. What steps does H&H take to promote regular HIV testing among older adults and encourage early detection of the virus?
So we have policy to screen everybody annually, more than just once in a lifetime, for 13 years and older, and this does not have an age cap. So this goes through the age spectrum. And in addition, all of our patients with HIV screen regularly for STIs. We acknowledge that sexual health care is a key component for overall health care, and we've identified ways to flag patients within our medical record who could be eligible for PrEP for prevention services, and this also does not have an age cap.
That's good. I like that. Are there any age-related considerations that it comes to HIV treatment and medication management for older adults, and how does H&H address them?
I think I mentioned that a bit with
You
the,
mentioned it, yeah.
polypharmacy, but part of the Ryan White funding that Dr. Quinn mentioned is increasing funding for pharmacists throughout our system that can help review medication lists, look for drug-drug interactions, and just medications that should be avoided in older patients in general. So that, in addition to the supports that I previously mentioned.
And that goes for the newly diagnosed too, I'm assuming?
Absolutely. We have numerous resources and supports for all patients newly diagnosed that can include applying for health insurance access. We have a way of, at health and hospitals, we're lucky to be able to provide access to health care and medications for all individuals, regardless of immigration status and ability to pay. So everybody is able to access HIV medication.
I think we start going there too with that one. How does H&H address the intersection of HIV and other health conditions that may be more prevalent among older adults?
So we care for the whole person. Some of the specific aging-related issues that we pay a lot of attention to, this is not an exhaustive list, but include frailty, social isolation, multimorbidity, including multiple comorbid conditions, cardiovascular disease, cancer prevention as well as treatment, neurocognitive decline, and polypharmacy. We're working with our geriatric experts across our system to really kind of infuse the model of geriatric care into HIV primary care, because we need to not just meet capacity, but really expand as this population is growing.
Thank you. I have a lot more good questions, but I have to pass it on to my chair because we have other colleagues here. We have to make sure that they can ask questions. Thank you.
Thank you. We'll come back to you, Chair Narcisse. Councilmember Brooks Powers.
Thank you, chairs, and thank you for the presentation, the testimony today. Just had a few really quick questions. In terms of facilities and staff, how many facilities offer HIV services to older adults? And I'm particularly interested in the location by borough, wanting to know where they are, and if you could provide a breakdown of how many medical staffers are currently working in these facilities.
Council member, can you clarify if you're asking about the entire city of New York or for health and hospitals?
I'm asking for health and hospitals. But if you have the full city data, it would be good to know too.
So we have 16 HIV clinics. I think here it's not listed by borough. Give me one moment. So Bronx, Morrisania, Jacoby, North Central, and Lincoln. In Brooklyn, East New York, Cumberland, Kings, Woodhull, and South Brooklyn, previously known as Coney Island, Manhattan, Gouverneur, Sydenham, Bellevue, Metropolitan, and Harlem, and Queens, Elmhurst, and Queens.
So in Queens, you have none for Southeast Queens. Hopefully when the, I guess the Gotham Center opens in Far Rockaway, that could be something that is included there to have some type of coverage. And in terms of the medical staffers?
In terms of the medical staffers, we have 80 HIV specialists across our system. I don't have the exact numbers per clinic, but our clinic sizes vary dramatically. It can be anywhere from 50 patients to 2,000 patients. And so our staffing models and needs reflect that variety across clinics.
And are you experiencing staff shortages? And if so, how many vacancies?
We're not experiencing any specific staffing shortages. We always evolve and restructure our teams based on our evolving patient needs.
And then lastly, I just wanted to also ask, I know a lot of older adults rely on local print media to get their information about resources that are available. Can you discuss the strategy you all use for outreach and hyper-local media outlets to ensure this information gets into communities like the one I represent, covering Southeast Queens and the Rockaways?
So, in terms of information accessibility, like I mentioned, we certainly rely on our partners and funded entities to do outreach among their specific communities. But in general, our information that is available online and all of our website pages are designed to be accessible for people with a range of different ability levels. And we are also making sure that all of our information is accessible to people who do not speak English. So all the health department public-facing materials are translated into several other languages. For direct services, we also have language access services available for translation. And specifically to Spanish, our sexual health marketing campaigns are also available in Spanish.
So to answer the question more directly, you do not do local print media advertising?
So that varies on the specific media campaign, which I don't have the details about in front of me.
Do you know if you've had any media campaigns covering local outlets in Southeast Queens?
We would have to get back to you about that.
If you will, please. Thank you. Thank you, chairs.
Thank you, Councilmember Brewer.
Thank you very much. I'm interested in the bigger policy. I remember when the previous governor, Deborah Fraser House, C. Virginia Fields, and others had a big press conference. We're ending the epidemic. That was a big press conference. And since then, I think you mentioned about, the commissioner talked about in his testimony, talked about the 9 sessions, et cetera. But is there like a piece of paper that says these are the 12 ways in which we are going to end the epidemic by X? And how are you working with the state on it? There's some question here that the state has appointed a community support person to talk about AIDS and HIV. I don't know if that helps. I'm not always a big believer in a person, but what are the actual steps and by what date? And what are we all doing to get there?
Yes, thank you for that question. So it was 2014 when New York State announced the plan for moving us to
I
end
remember all the characters.
The AIDS epidemic. And actually, we had made a lot of progress as a state by 2019 in reducing the number of new HIV infections to be below the number of deaths that year among people diagnosed with HIV. So that was like a key milestone in our ending the epidemic
That was
plan.
in 19 is what you're saying.
That was in 2019. Then in 2020, there was the COVID-19 pandemic, and that really impacted availability and uptake of HIV testing, prevention services, just access to care in general was really impacted.
But now we're in 20
during that year.
That's
yes.
over.
So then in the New York State Department of Health after 2020, with local health departments like New York City, revised the ending the epidemic timeline and pledged to reach those end the epidemic goals by December 2025. And so those revised end the epidemic goals informed the city goals. That is included in the New York City 2020 Ending the HIV Epidemic Plan, which was released in March of 2021. And then following that, there was a New York City Integrated HIV Prevention and Care Plan that came out in 2022 to cover the years 2022 through 2026. So we co-authored that with the New York State Department of Health and Nassau County Department of Health. So what's in the HIV epidemic plan? I think it was the second part of your question. So this plan includes 7 priority populations, one of which is the focus of today, which is people ages 50 years and older. There are some specific key activities focused on older people with HIV. That includes improving access to comprehensive and integrated health care that is person-centered and responsive to complex medical comorbidities that Dr. Kaplan has been describing really well, to increase engagement with behavioral health care of people ages 50 and older, to support strategies and programming to address social isolation, nutrition, exercise, and other health maintenance needs for this population, to ensure services address the needs of those with social isolation or limited mobility by using telemedicine, in-home visits, or transportation services, addressing technology challenges that are sometimes encountered by people ages 50 and older through increased education on different modes of technology, supporting housing models and other interventions that promote intergenerational contact.
That's a nice idea, but it doesn't happen. Go ahead.
So these are like a broad set of things that are included in the HIV epidemic plan. I'm just talking about the ones that relate to people age 50 and older today, but I certainly would direct people towards both the 2020 Ending the HIV Epidemic Plan and the Integrated HIV Prevention and Care Plan for more specific details. Okay, and certainly there are things in those plans that require beyond the health department to, as the commissioner described, a whole of.
Well, I know my time is up, but you think you're going to make the 2025 December, and does your data show you that it's possible?
So
That's a
we
very
believe it's
short
not possible.
timeframe.
We believe it's possible to end the epidemic. We will have new data for our 2022 HIV surveillance data will be released around World AIDS Day this year, coming up on December 1st. So that'll be another checkpoint for us.
Okay, and then what would take? Would the state be updating the date if they're not going to make the 25? How does that work? I hope it makes it. I'm interested in ending this epidemic like everybody else. Well, you think you're going to make it? Is that what you're trying to tell me?
Yeah, I can't speak specifically to New York State's plans after next year, but.
But you coordinate with them?
We definitely coordinate with them, yeah.
All right, and one more last thing. I'm just a huge SAGE fan. I just want to make that clear. Thank you.
Me too.
Thank you, Councilmember Brewer. I'll now turn it over to Councilmember Rivera.
Thank you very much. And I want to thank the chairs for their openings because I know, Chair Hudson, you mentioned just socialization and mental health, and Chair Shulman and Narcisse as well, just really covering the needs of tens of thousands of New Yorkers at this point. And I was pleased, you're always pleased to see the data. I feel like so many of us know individuals who have lost their lives to this disease, but many of us do know people that are in our communities, and some of them are thriving. Some of them are doing really well. I know constituents who have lived for decades living with HIV. And then I also know others who I feel are really experiencing mental health distress. It is, I feel like geriatric mental health, which is what we call it, I know that's broad and that includes people living with HIV, are really some of the first programs to get cut in the budget. And we're very, very worried. And I just want to thank the chairs again for having this hearing. So we had some good news, right? 83% living virally suppressed. I think that's good. That's good data. People are living their healthy lives. But you capture demographics clearly. Black and Latinos disproportionately affected. Do you have the neighborhoods where individuals living with HIV live? Did I miss that?
We certainly have information on that, and in the annual HIV surveillance report that the health department issues usually around December 1st of each year, there's breakdowns by boroughs. So I don't have it right in front of me to talk about today, but I would certainly direct people's attention towards our HIV surveillance report, and many years of those are posted on our website, but the newest one, which will reflect 2022 data, will be released at the end of this month.
Okay, thank you. So you track their needs, right? You track individuals, their priorities, what they ask you for?
So we're not able to track that kind of qualitative data through surveillance. We're mostly looking at lab-reported data and case investigations, but how we find out about needs of people in the community is through some of the mechanisms that I've already described earlier, like our HIV planning group, like the HIV Planning Council of New York, for example. So those kinds of touch points, as well as working with the providers that we're funding to do this work in the community and understanding what their experience is in delivering the services.
I only ask, and I'm going to wrap up, because I have constituents who even live in supportive housing in my district who are asking for basic things like food. This is an incredibly expensive city. Many people are living on a fixed income, very, very low income, and they can't even afford the food. And my neighborhood is actually, we're geographically one of the lucky ones. They can go over to Chelsea and get those quick use services. They can go over to community-based organizations like SAGE. But why I asked about the neighborhoods is because what Councilmember Sanchez said is so important. Not everybody can get to Chelsea and Fort Greene. And when we're looking at where Black and Latinos live disproportionately in New York City, that's much farther away. Those are in outer boroughs. Those are in transit deserts. So we just ask that, you try to work with us and we'll be there for you. The socialization is so important, the isolation, the mental health, the outreach specifically to neighborhoods that are typically underserved. We hope you'll step that up, and we hope to be partners.
Thank you.
Thank you.
Thank you, Council Member. Okay, I have 6 questions that I hope will take no more than 12 minutes, and then I'm going to turn it over to Chair Schulman. Oh, she doesn't have any more questions. Okay. After my questions, we'll take a quick bio break, and then we'll get into the public testimony, okay? What efforts are being made to address social and economic challenges faced by older adults living with HIV, including housing instability and poverty?
Yeah, so I think we heard a lot of really excellent information from Dr. Kaplan-Lewis about some of the direct clinical services that are provided to HIV patients in the H&H system, as well as how those are connected to the needs that they have to support their social determinants of health. I would just mention also that there is a comprehensive universe of Ryan White services that are available to anyone who's eligible that meets the income requirements for Ryan White eligibility, and that really includes all of the things that support someone's ability to maintain their treatment on HIV, so food and nutrition, emergency financial assistance, housing, early intervention services, harm reduction services. There's a lot that's supported by that program that addresses the question that you're asking.
Thank you. Are there specific policies or programs in place to address the stigma and discrimination faced by older adults living with HIV?
I've talked about this a bit earlier, but certainly stigma and in particular issues related to age are certainly a concern for us in terms of making sure that people are able to access and willing to access HIV testing as well as care and treatment. So we work with all of our partners and providers in New York City to try to address some of those issues.
What measures are taken to ensure that healthcare providers and support services are culturally sensitive and responsive to the needs of older adults from diverse backgrounds?
Yeah, so that's something that we work closely with for funded providers, that the health department has expectations around sets, but we also work with other providers in New York City to make sure that they understand like what are the requirements around testing. For example, New York State removed a limit for annual HIV testing required in primary care settings in 2016, so we're constantly educating providers about those kinds of topics.
And you've addressed this question specific to other statements that you've made and programs, but just overall, how does the city evaluate the effectiveness and impact of its programs and policies targeting older adults living with HIV?
Yeah, so in addition to monitoring the individual programs and soliciting input from our stakeholders on all of the programs as we move along, we're also certainly utilizing our surveillance data that I've also talked a little bit about to understand where we are in the epidemic and where more effort needs to be put.
Anything from NYC Aging on that one?
So like our colleagues, we're very committed to evaluating the effectiveness of our variety of programs through KPIs and opportunity to come together, review data, and use it to drive continuous quality improvement across our program portfolio. We have individualized metrics that are developed that are specific to the outcomes related to each of our various programs. And we rely on our partnership with the health department as well as health and hospitals to address the healthcare and medical needs of older adults living with HIV.
Thank you. How does the city assist older adults in accessing adequate insurance coverage for HIV prevention, treatment, and supportive care? Does NYC Aging still provide assistance through the Health Insurance Information Counseling Assistance Program?
Yes. New York City Aging Older Adult Centers provides case assistance to older adults who are navigating many processes regarding the benefits that they need. This can include insurance coverage, which relates to specific health care needs and what benefits they're entitled to. We work the HICAP program, which stands for Health Insurance Information Counseling and Assistance Program, is designed to support older adults in navigating specific Medicare coverage questions related to their health care needs, particularly around moments such as right now where we have open enrollments and get a very large volume of calls every day to help support older adults in navigating these often complex systems.
Thank you. And then regarding intro number 623, which is anti-discrimination training on sexual orientation, gender identity, and expression for senior service providers, what anti-discrimination training or guidance does NYC Aging currently provide to service providers? Are all contracted providers required to administer anti-discrimination trainings for staff? And do these trainings include information regarding discrimination based on sexual orientation, gender identity, and expression? And what about HIV status? And I'm happy to repeat any of that if needed.
We agree that this is a very important issue. As with any new training for human service workers, we want to ensure that the development and implementation is carefully considered. We're still reviewing the particulars of the bill and its impact on our programs and providers. We welcome continued conversation with the council regarding the intent.
Okay, thank you. Any other questions from my colleagues at the moment? Okay, great. We're going to take a 3, maybe 4-minute bio break, depending on how long the lines are. And then we'll come back to public testimony, which we're eager to hear. Thank you. Okay, thank you so much for your patience. I know our line of questioning took quite a while this morning, so I appreciate everybody's patience in staying here. We're going to get started with the first panel of those testifying, and our counsel will call those names. And I apologize, I want to just acknowledge Councilmember Velasquez, who has joined us. Thank you.
Thank you, Chair. Good afternoon, everyone. Thank you for your patience. Just a reminder that you will have 72 hours after the close of this hearing to submit written testimony. We do encourage you to submit written testimony. It is all read and considered by the committee staff, and we greatly appreciate the work that you put into it. We will be doing some hybrid panels today, so that'll be a mix of in-person and virtual folks. And so just folks who are testifying virtually, please just be on notice that your name might be called. And so our first panel is going to be MJ Akma, Darcy Connors, Samuel Sheldon, all in person, and then Terry Wilder, William Knowles, and David Martin on Zoom. We're going to start with the in-person individuals, and then we'll move to the folks I called on Zoom. And MJ, you can begin when you're ready.
All right, good afternoon. My name is MJ Okma with SAGE, stepping in for Darcy Connors, who's the Executive Director of SAGE Serves, the Direct Service Division of SAGE. Our programs include dedicated services for older New Yorkers living with HIV, behavioral health services, outreach programs, special programming through our network of LGBTQ+ affirming older adult centers. I feel like it's important to state, given the testimony we heard earlier this morning, that HIV is not just an LGBTQ+ issue, and there are many older New Yorkers who need HIV services who will need to access those differently than through our older adult center system. Additionally, there are clear silos regarding this issue that need to be broken down between departments to ensure that our city can best service this population. What I wanted to speak to this afternoon was the impact of HIV-related stigma and ageism on older adults living with and vulnerable with HIV. Ageism is discrimination based on age and has severe consequences like increased mortality rates, compromised health, accelerated aging, mental health and cognitive decline, and diminished quality of life. HIV-related stigma, characterized as a negative attitudes towards individuals with HIV, is a significant barrier to effective HIV care and quality of life. Older people living with HIV experience the intersectional of stigma resulting from both HIV stigma and ageism, which results in compounding discrimination, creating the need for dedicated funding and policies to reach this community. There are several ways the city can help combat this intersection of ageism and HIV-related stigma, including training healthcare providers on HIV screening, early diagnosis and treatment for older people, allocating funding and implementing HIV prevention, education, social services, and outreach initiatives specifically for older adults, developing tailored HIV treatment and prevention guidelines for older adults, creating and rolling out an intersectional HIV stigma and ageism campaign, and training social service providers on the unique needs and experiences of older adults living with HIV. SAGE also supports Intro 623 to train aging services providers on preventing discrimination on the basis of sexuality, gender identity, and gender expression, but strongly recommends adding HIV status to that bill. Let us work together to create a free, stigma-free city. Thank you so much for this opportunity to testify and for holding this really important hearing.
Thank you, MJ.
Hello, my name is Sam Sheldon, and I am the manager of the SAGE Positive program. SAGE Positive provides direct support to LGBTQ older adults over the age of 50 who are living with or potentially impacted by HIV. SAGE has offered services to the HIV population since the beginning of the epidemic, programs like what has now become the longest-running support group in the United States for older adults living with HIV. In 2016, the SAGE Positive program was formed to consolidate SAGE's HIV, STI, and sexual wellness programming under one roof. The program offers case management, wellness workshops, support groups, and referrals to other mental health services. Time and time again, when we perform needs assessment surveys with our participants, their primary interest is in social events to connect them with others in the community. When working closely with our participants, I often hear them talking about loss. The loss in the 1980s and 90s of their peer group during the AIDS epidemic, the loss of connectedness and loved ones due to aging. It's my belief that these sustained and compounded emotional losses are a large part of the statistically higher rates of loneliness, isolation, and a sense of stigma that we see in older adults living with HIV, specifically in the long-term survivor community. The HIV support group that I facilitate is a method to foster resilience and social connectivity and to address issues not only around HIV, but around aging. What's it like to encounter multi-morbidities that are common in long-term survivors? What it means to navigate a post-pandemic New York City with fewer loved ones and a changed environment. How history of past losses contribute to an even augmented sense of current grief. One of the other pillars of SAGE Positive is HIV and STI prevention through the larger lens of sexual wellness, looking at what sex and intimacy are like as we age, and how we as providers can support risk reduction practices in populations who still have many questions or even ambivalence around PrEP or around U equals U, undetectable equals untransmittable. These conversations are especially important because our participants report that they are rarely happening among their peers and almost never occur in the doctor's office. I'm excited to announce that thanks to recent funding from ViV Healthcare, we are creating the SAGE Center for Sexual Wellness and Aging, which will feature workshops, trainings, and support groups, both for the entire LGBTQ+ older adult community, and more specifically for those of our participants who are aging with HIV. Programs like these are effective and impactful, but as has been mentioned today, these programs are not accessible to all New Yorkers who would benefit from them. The city should foster the creation of more programs such as SAGE Positive and our new Center for Sexual Wellness and Aging. New York City must also allocate resources to develop HIV prevention campaigns catered to the unique needs of older people who are so often left out of educational outreach campaigns, and to educate community organizations like older adult centers and like medical providers on how to initiate these important conversations. Thank you so much for this opportunity.
Thank you, Sam.
Thank you. We're going to be moving now to folks on Zoom. Terry Wilder, please wait for the Sergeant at Arms to call time before you begin your testimony.
Time starts.
Terry, are you on?
Yes. Hi. Yes, I just wasn't unmuted. Apologies. Good afternoon. My name is Terry Wilder, and I'm the HIV and Aging Policy Advocate at SAGE. I'm a social worker by training, and I've worked in HIV since 1989. I served on the Governor's Task Force to End AIDS and currently serve on the New York State Department of Health AIDS Institute subcommittee charged with making sure we're implementing the governor's plan. When I first started working in HIV, many of my clients died. Death surrounded me. It was really challenging to be hopeful because we didn't have effective treatments. That really all changed in 1996 because of science. And, you know, I need to be honest and tell you that I never thought that I would be in front of you today in 2023 talking about aging with HIV and the needs of older people with HIV, because we just didn't think people would live that long. I'm incredibly grateful that people with HIV are aging and living longer. However, we have an imminent crisis that we're facing in New York City. The community of people who are aging with HIV is growing rapidly, and in 10 years, our healthcare system will be completely overwhelmed. I want to highlight a few issues that are particularly concerning to me. As people grow older with HIV, their care becomes more complex. They're more likely to experience cardiovascular disease, malignancies, osteoporosis, cognitive impairment, frailty, and disability. And because of this, they're more likely to need long-term care. This not only includes care that would be provided at a long-term care facility like a nursing home, but through home care services. We really must consider the unique needs of the community as they age and ask ourselves, are these facilities ready to take care of older people with HIV? Are the home care agencies prepared? If 80% of all people living with HIV in New York State live in New York City, and 25% of them are over the age of 60, do we have the system, services, and resources in place to care for them with the complex needs that come with growing older with HIV? I really want to state how imperative it is for us to create provisions of care that make it easier for people with HIV to age in their homes. I don't know one person who wants to end up in a nursing home. And while that will be the case for many, I want us to really think about how we can make it possible for people aging with HIV to live in their homes for as long as possible, really ensuring that individuals aging with HIV can access those home health services. Because honestly, this is vital for their well-being and independence. Home care services play a crucial role in allowing individuals to age in the comfort of their homes, maintaining their independence and preserving their quality of life. Home health is key to allowing people to age at home. And finally, we've repeatedly heard about the profound impact of isolation and loneliness on people aging with HIV. Adequate funding for recreational activities, social programs, supportive counseling, and mental health services to keep this community connected and supported is essential for their mental and emotional well-being. And I'd love to hear more details on how the New York City Department of Health and Mental Hygiene specific HIV program is working to address these issues via their resources and funding. We cannot afford to wait any longer to address these issues. And while I was only able to touch on a few things, I want to stress that together we can develop a comprehensive plan to allocate resources, enhance care, provide the necessary support, and ensure that those aging with HIV can live healthy, fulfilling lives with access to long-term care services they need and deserve. Thank you for your attention to these critical issues.
Thank you, Terry. And I'd like to acknowledge that we've been joined by Councilmember Dinowitz.
Thank you, Chair. We'll be moving on to William Knowles. Please wait for the Sergeant at Arms to call time before you begin your testimony.
Time starts.
William Knowles,
Yeah,
you can begin when ready.
okay, I'm trying to find out where the, oh, here it is. I was not prepared to speak today. I just thought I was here to listen. But I do have a few things to say. I'm a longtime recovering addict. I have like 29 years of recovery. And I found out that, you know, the longer I stay clean and sober, the mental illness and the need for social workers are greatly needed, and they're very difficult to find. So the isolation and everything that everyone's talking about is very, very real. It's happened to me, and I'm very concerned about, I recently became a SAGE member of Harlem. I've also gone to 305, but I started a fashion art class at SAGE Harlem, and it's given me some comfort because the people in the class really enjoy the class. It's something new as an art class, dealing with fashion and art. And I'm really concerned about these services being cut because of the migrants and the money, the budget cuts. I'm not sure what else I would do. Also, I'm living in a 80-20. I was lucky enough to get an apartment. I've been here about 7 years so far as the housing is concerned. And I really, really like my apartment. I love where I'm at, but I have a big problem that's causing problems with my mental illness. And I've had to go all the way to the borough president's office to try to get some kind of help about it. Lifetime Gym has a outside pool that's directly above my apartment, and
Time expired.
pardon me?
Time expired.
Oh, time expired?
You can finish your thought, Mr. Knowles.
Oh, okay. So, yeah, I'm just trying to get moved to another apartment, and that's been a issue for me trying to get moved to another location in the building. But all the things that are being said are correct, and especially healthcare also.
Thank you so much for your testimony. We can follow up with Sage to be connected with you and see if we can assist with your housing situation.
Thank you so much. Just a note from the committees that we are giving everyone 2 minutes for their testimony. We have a lot of folks signed up, and we want to hear from as many people as possible. We are going to be moving on to David Martin on Zoom. Please wait for the Sergeant at Arms to call time before you begin your testimony. David?
Time starts.
Good afternoon, council members. My name is David Martin, and I work as the SAGE Positive Program Coordinator at SAGE. I am a volunteer appointee of the HIV Health and Human Services Planning Council for the New York EMA and serve on its executive committee. I am also an older New Yorker living with HIV for 36 years. The issue I want to raise this morning is that significant disparities exist for older New Yorkers living with HIV when seeking timely and comprehensive health care and wraparound services. What is evident through my individual experiences, hearing stories from the community, and from working for the SAGE Positive program is that older New Yorkers with HIV are often unable to get their needs met and face barriers doing so. HIV stigma, ageism, classism, homophobia, transphobia, and racism have all resulted in limited investments in prevention, medical, and social services. Direct support is needed to navigate a complex healthcare system to even access services. Many older people with HIV encounter a high volume of healthcare needs, high and unaffordable costs, perplexing insurance plans, as well as personal factors that make accessing needed services more difficult, such as comorbidities, cognitive difficulties, language barriers, and immigration status. However, the New York City Council can help tackle these issues by creating a City Council initiative on HIV and aging, which includes funding for healthcare navigation in next year's budget. It must also be stated that challenges do not stop once an individual successfully makes it to an appointment. Current clinical practices fail to best serve older New Yorkers living with HIV.
Time expired.
Older people with HIV require more time with our providers and different approaches to addressing the evolving and already complex intersection of comorbid conditions, yet only a customary 20-minute appointment is allowed. Oral health is paramount to nutrition. However, for older adults with HIV, tooth loss limits this due to improper food mastication. Implant treatments with greater effectiveness are needed. Sadly, insurances only cover ill-fitting, painful, and less effective devices currently offered. In closing, we need providers to conduct routine age-related assessments earlier and have the most updated training and resources about the persistent impact that HIV and trauma have on the aging process. Providers should be required to make certain that insurance covers different doctors or services before they make referrals to help prevent loss or delay of long-awaited appointments. Social services and healthcare have not centered focus on the ongoing needs of older people living with HIV, and it is time to change course. Thank you so much for the opportunity to testify. We look forward to working with you to address these and other concerning issues.
Thank you, David.
Thank you very much to this panel. We're going to be moving on to our next hybrid panel. In person, we would like Tanya Walker, Michael Earp, and Robin Martin, and Valerie Reyes Jimenez, Arthur Fitting, and Nicholas Montadoro. On Zoom, we'll be hearing from Lilibeth Gonzalez and Jason Sanciato. And we'll start from our left, your right. So we'll start with you, and then we'll just go down the table, please. And you can begin when ready.
Good afternoon, yes. Thank you, Chairs Hudson, Shulman, and Rivera, and members of the Committee on Aging, Health, and Hospitals for the opportunity to provide testimony on older adults living with HIV on behalf of VNS Health, formerly known as the Visiting Nurse Service of New York. My name is Arthur Fitting. I'm a nurse. My pronouns are he, him, his, and currently I've been working with VNS Health for 30 years, and currently I'm the LGBTQ+ program manager. For nearly 130 years, our organization has provided high-quality, cost-effective care to underserved and marginalized communities throughout New York who are otherwise shut out of the healthcare system. VNS has been a trailblazer in home and community-based care for decades, specializing in serving the LGBT community and those living with HIV. We lower the institutional barriers to care by meeting our patients where they are most comfortable in their own homes and communities. Just some of our programs include the Gender Affirmation Program, our LGBTQ+ adult program, our LGBTQ Community Outreach Initiative, our HIV Special Needs Medicaid Health Plan called Select Health. VNS Health is the largest healthcare organization in New York with Sage Care Platinum LGBTQ+ cultural competency credentials, meaning more than 80% of our staff are trained in working with LGBTQ communities. As a healthcare partner serving the diverse neighborhoods and boroughs in New York City, we play a vital role in caring for individuals transitioning from hospitals, healthcare facilities, and medical offices back to the comfort of their homes. VNS Health directly impacts the lives of over 50,000 New Yorkers each day. Delivering care in the familiar surrounding of one's home gives us a unique opportunity in healthcare education and enables us to assess and address an individual's health needs at their doorstep. Throughout its history, VNS Health has demonstrated a commitment to supporting the care to all New Yorkers without discrimination or financial constraints. We have a history of providing home health care and adapting our service delivery to meet the needs of thousands of patients, particularly during the AIDS crisis. Our goal has always been to enable individuals to remain in the comfort of their homes where they wish to be. Being able to provide health education to people in their homes where people feel most comfortable to listen and learn allows us to support their health and wellness in a very unique way. Having built coalitions and so many community-based organizations allow us to share health education with community members in the environment they feel safest in. Having a large footprint in so many communities permits us to address community-centered health equity and health educational issues. VNS Health is actively engaged in an ongoing LGBTQIA research project in collaboration with community-based organizations. Through this initiative, we gather valuable insights from focus groups, enabling us to tailor health services and programs to meet the unique needs of individuals looking to age safely and comfortably in their home. VNS Health supports your legislation today.
Thank you so much, Arthur.
Thanks.
Okay, we can proceed.
Hello, I'm Tanya Azapanza Johnson Walker, and I am 60 years old. I'm a combat engineers Army veteran, and I was diagnosed with HIV 26 years ago here in New York City. When I received my diagnosis, I didn't know what I was going to do. I had many friends who died from HIV. I didn't think I was going to live to the age of 60. I thought I would be dead at 22 when I left the military. When I first was diagnosed, it changed my life. I was diagnosed with HIV. It's a journey that has been both personal and shared and shaped all the experiences in my life. It's a journey that I believe began long before my diagnosis. I believe I was HIV positive before I was actually diagnosed. When I did go, I went out of curiosity. You know, I didn't think that, I didn't think I would be positive, but I did end up being positive. The catalyst for my decision to get tested was curiosity, born out of the devastating loss of many close friends right here in the heart of New York. Their deaths were a stark reminder of the urgency surrounding HIV, a virus that doesn't discriminate based on friendship or familiarity. It can touch anyone, and it touched my inner circle deeply. Today, I bring forth not only my story, but a passionate plea for change as we confront the complexities of HIV. It becomes evident that the battle extends beyond medical interventions. It is a battle against discrimination, against the barriers that hinder our ability to provide care, support, and understanding. One crucial aspect of this battle is the dire need to invest in low-income housing for individuals living with HIV.
You can finish it.
Okay, I can finish. Stable housing. Currently, I live in an apartment in Harlem, and it's very hard to get repairs from my landlord. I mean, the kitchen floor is messed up. There's mold and mildew in the bathroom, and I think it's very important that we have access to safe, low-income housing. When I was younger, I didn't know I was going to live this long, so I didn't. I don't have retirement money. I don't have some of the things people have, currently. Moreover, our efforts must extend to the realm of culturally competent service providers. Discrimination, whether subtle or overt, can be a formidable obstacle for those seeking care or culturally competent care from service providers. Understand the nuances of diverse communities, creating an environment where individuals feel respected and are understood. This not only fosters trust, but also eliminates additional burden of discrimination that many individuals living with HIV already carry. To truly combat discrimination, we must prioritize the training and education of service providers, ensuring that they're well-versed in the cultural nuances of populations they serve. And investment is not just financial, it's an investment in compassion, empathy, and the human connection that is essential in healthcare. In conclusion, as we navigate the complex landscape of HIV, let us remember that the fight goes beyond medical treatments. It's a fight for dignity, equality, and a future where no one has to face discrimination because of their health status, and again, invest in low-income housing, and provide stability and empower service providers, and also more funding for organizations who provide care for seniors living with HIV/AIDS. So thank you.
Thank you so much, Tanya. And we can also be in touch regarding your housing situation.
Oh, thank you.
Hi, everyone. My name is Valerie Reyes Jimenez. I am the New York City Community Organizer for Housing Works. I am a 42-year long-term survivor of HIV. The testimony that I'm about to give today, I've submitted official for Housing Works, but most of the remarks that I'm going to be making are going to be personal at this point. So I came to Housing Works homeless and at the lowest point in my life in August of 1991, and I now work full-time as part of the Housing Works Advocacy Department. Housing Works was founded in 1990 with the mission to end the dual crisis of homelessness and AIDS, and currently provides a full range of integrated medical, behavioral health, housing, supportive services for over 15,000 low-income New Yorkers annually. And our focus is on the most marginalized and underserved people, those facing challenges of HIV, mental health issues, substance use disorder, and other chronic conditions and incarceration. Housing Works is deeply grateful to the council for its consistent support for implementing New York's plan for ending the epidemic and for today's focus on the unique challenges facing older adults living with and vulnerable to HIV. We also support all of the initiatives and resolutions before you today and urge for your continued support of the council's ending the epidemic, including and opposing all proposed cuts that are coming up. I am a native New Yorker, as are my children and grandchild, and I never expected to be pushing 60. I never expected to see my son turn 2 years old, much less 35. My daughter, age 40, is a New York City high school math teacher with the DOE who once worked at our syringe exchange program. And I have a fierce, beautiful 21-year-old granddaughter that is beyond my wildest dreams. I have a quick message to the mayor that if we placed our homeless New Yorkers, whether native, transplants, or newly arrived, in apartments instead of shelters and hotels, we would probably save $3 billion in this budget. So, and additionally, any cuts to the DOE, stop messing with our children. They're the future of our city, and there's got to be something better. There's got to be a better way. There are 4 simple steps to stopping the HIV virus. There's 4: testing, treatment, prevention, and housing. Homelessness was and still is a major social driver for becoming HIV positive and not being able to receive appropriate medical treatment. Then there's the stigma that's associated with HIV. Everyone has an HIV status. You're either positive or negative. If you're positive, welcome. You can now get early treatment and thrive. If you're negative, congratulations. There are things you can do to remain that way, including taking PrEP and testing annually to maintain your status. Testing must become routine until HIV testing is not, until that happens. HIV stigma will continue to be perpetuated. Doctors at certain populations, we're going to test you for X, Y, and Z, and then whisper, we're going to test you for HIV. Is that okay? And that is not cool. It has to become regular, has to happen all the time. Most older people that I know, like Tanya, don't have the finances needed to retire or grow old. I certainly never planned for a future, and why should I have? I shouldn't even be alive today, but I am. I can't retire. I have to work until I die, until my body says, that's it, no more. I take 1 pill a day for HIV, which ironically is one of the least of my problems. The other fistful of medications that I take daily are for severe chronic pain, depression, anxiety, nerve damage, muscle spasm, migraines, high cholesterol, and then on top of getting older, things are starting to slowly and painfully break down. So the lipodystrophy on my body has developed and is one of the worst symptoms that I grapple with. It's like permanently having a 20-pound bag of rice strapped to my front of my body, and as a result, my body dysphoria and self-esteem has taken a giant, huge hit. So I come before you today to emphasize the importance of safe, stable, and appropriate housing for older people with HIV. Housing Works is an organization that for 33 years has fought for the safe and stable housing of people living with the virus and for people at risk of HIV transmission, including those with substance use, mental health complexities, and we know that housing is health care. I'm going to skip a whole bunch of this, and I'm just going to go straight over here to the end and say that I would like to invite everyone that's here today to our World AIDS Day event that is happening at the AIDS Memorial on December 1st. We'll be there from 10 a.m. to 6 p.m. We'll be reading the names of people that have passed away from HIV. We have binders upon binders of names, and everyone, there's plenty of time, plenty of microphones for people to come down and do that. So my written testimony includes more information and proposals on meeting needs of older people with HIV, so please consider my voice and those of your constituents during any discussions of future budget negotiations. And thank you for your time.
Thank you so much, Valerie, for your testimony. And I'll just add, you said permanent housing will probably save money. It's known and factually proven to save money. Permanent housing is cheaper than temporary shelter. So
let me know what I need to do to help you push that, because I am all down. Yeah, let's do it.
Thank you.
My name is Michael Earp. Okay.
As long as the light is on, you're good.
Yep. My name's Michael Earp. I'm 67, and I've had HIV for 30 years. And I'm going to compress my 2 pages into sort of a restatement of what Terry from SAGE said virtually, which is that home health care is probably what my 2 pages are all about. A companion who, SAGE currently has a volunteer buddy program. That's somebody who usually goes for an hour a week, but it's not somebody who can carry or pull the grandpa wagon from GMHC, which I do, that has a 7-pound bag of potatoes, 5-pound cabbage head, tofu, 10 cans of vegetables, and milk. And if there were a companion who could help me, or the person behind me who actually only had one arm recently, to get those groceries home, right? It's kind of, after all these years, figuring out where the elevators are, right? Also, I want to speak on behalf of 2 of my friends who live on the 5th floor and the 6th floor of walk-up apartments. HIV-positive LGBTQ elders. They don't go out so much. I'm not sure those grandpa wagons get up there. Thankfully, one of them has the means. So I really want to thank the Gay Men's Health Crisis. It's been invaluable to me and still is. I want to thank the 13th Street Gay Center and also SAGE, the Edie Windsor Center, where I and my husband go for dinner and meditation. And thank you, New York City, for providing what's kept me, I think, alive, and also the ADAP program, New York State.
Thank you, Michael, for your testimony.
Thank you. My name is Nicholas Montadoro, and I am a Government Relations Associate at Emblem Health. On behalf of Emblem Health, I would like to thank Chair Shulman, Chair Hudson, and Chair Narcisse, and the members of the committees on health, aging, and hospitals for holding this hearing and providing the opportunity to express our support of the citywide population health agenda aimed at improving life expectancy. The Emblem Health family of companies provides insurance plans, primary and specialty care, and wellness solutions. We operate 14 neighborhood care centers where we provide free support, connections to resources, and programming to all community members. Many of our centers are co-located with our partner medical practice, Advantage Care Physicians, which provides primary and specialty care at over 30 offices in the New York area. Our experience in all of these areas makes us uniquely positioned to advise and coordinate with the city in the efforts to extend the lifespan of New Yorkers and to improve population health. We were encouraged by the announcement of the Healthy NYC plan to advance these efforts, and Emblem Health CEO Karen Ignani has committed to aligning to this work. We would like to work closely with you and to help shape the city's population health agenda and offer Emblem Health as a resource. We know that health outcomes are affected by more than just individual actions, and we will continue to work to ensure that all communities have access to the services they need. Our commitment to reducing inequities was recently recognized when we were awarded Health Equity Accreditation from the National Committee on Quality Assurance, the first health plan operating in New York to receive this designation across all lines of business. We place health equity at the forefront of everything we do, and we strongly support Introduction 1248. At the development of a Healthy NYC population agenda, as well as the legislation considered today related to expanding access and availability of mpox education and vaccines, STI testing, and HIV and AIDS prevention. We hope to continue to be a constructive partner and resource to the City Council and look forward to continuing to work together. Thank you.
Thank you so much, Nicholas. We're just going to hear from Chair Shulman for a moment.
Yeah, I have a meeting that I need to go to, but I just want to say the committee council is going to be here. And as I said in my opening remarks, we haven't had a hearing about this, about HIV in older adults, since 2006. So I'm so glad at all the people that have come out today, both online and in person. I want to thank Chair Hudson and Chair Narcisse for their collaboration, and we look forward to making sure that we have the services we need for, as an older adult, I'm telling you that I'm looking forward to having services. And I worked for Gay Men's Health Crisis at one point, so I'm very proud of that too. Thank you very much.
Thank you, Chair Schulman.
Okay, and now we're going to be hearing from, on Zoom, Lilibeth Gonzalez. Please wait for the Sergeant at Arms to call time before you begin your testimony. As a reminder, you'll have 2 minutes.
Time starts.
Hello, thank you, Chair Schulman and Chair Hudson and the committee members for the opportunity to testify. My name is Lilibeth Gonzalez. I am a 68-year-old woman who's been living with an AIDS diagnosis for 31 years. I also work at Gay Men's Health Crises, the HIV and Aging program. I have already lived past my expiration date because we were all given a few months to live. I have faced many challenges, physical and mental challenges, but more support is needed because we in the HIV population just want to be able to live long and healthy lives. So more support is needed to ensure we do so. New York City must do a better job of meeting the needs of older people living with HIV and AIDS by expanding access to vital services like affordable health care, food security, accessible housing, and long-term care facilities, mental health, and substance use counseling. Two of the most pressing needs are housing and food security, because without them, it's impossible to take care of ourselves. Access to healthcare services, we won't be able to have that. We can't maintain treatment, support groups, and connection to other communities are also very important, such as technology, okay? Laptops, iPads, smartphones are also necessary to combat social isolation and depression, as well as to participate in virtual programs and telemedicine. Seeing this need, I created and facilitated a support group at GMHC, Gay Men's Health Crisis, and it's called Thriving at 50 and Beyond, which is for people over the age of 50 living with HIV. We need more funding for programs like this across the city in safe spaces that we can call home. Another major issue that I have experienced is that society does not often think about older people living with HIV. So this hearing is a good step, but we must consistently be part of the conversation to inform elected officials and community leaders about developing more solutions. These solutions include increasing HIV testing for older adults, requiring training on the topic of HIV and aging for medical and social service providers, and advocating with us to ensure we can access the medical treatments we need to thrive. Thank you again for the opportunity to testify, and I look forward for more discussions. Thank you very much.
Thank you, Lilibeth.
Thank you so much. We'll now be hearing from Jason Cianciato. Please wait for the Sergeant at Arms to call time before you begin your testimony.
Time starts.
Thank you. Chair Schulman, Hudson, Narcisse, and committee members, I'm Jason Cianciato, the Vice President of Communications and Policy at GMHC, founded in 1982 as Gay Men's Health Crisis. You already heard from my colleague Lilibeth about her personal experience and her wonderful work on our HIV and aging program. So I'm going to focus briefly on two other items on the agenda. First, I want to focus on Intro 0620 and our collective work to prevent future mpox outbreaks. GMHC was fortunate to be able to receive funding at both the city and state level, and our last batch of funding ended at the end of September. Some brief outcomes. We served over 7,600 individuals reached by direct street outreach through over 900 in-person canvassing hours, and also facilitated over 1,400 vaccine referrals. This outreach occurred in 4 of the 5 boroughs. On social media, we reached over 225,000 impressions, 8,200 engagements, and 6,800 link clicks to various services, including city services at STI clinics to get a vaccine. Some of the questions that we've been asked are really important to what this intro is talking about, which is what happens now? When do people who already got a vaccine series need to get vaccinated again? How long does it last? And we really need city and state funding for GMHC to continue this work. I also want to support Intro 1248 because I think it's a critical part of the shared vision that GMHC and the council has, not just helping to heal wounds that already exist, but to prevent those wounds from happening in the first place. We're not going to end HIV and AIDS until the disparities that lead to these harms happening, often when our community members are young, are taken care of. And GMHC looks forward to working with you in this and so many other matters. Thank you so much.
Thank you, Jason.
Thank you so much. Thank you so much to this panel. We'll be moving to our next panel now. I'm going to be calling, and I apologize for any mispronunciations of names, Faris Ilias, Amanda Lugg, Camila Sofia Gomez, Christian Gonzalez Rivera, Ruth Finkelstein. Okay. And you can proceed when ready.
Sure. Good afternoon. Thank you for organizing today's hearing. My name is Faris Ilias, and I work for the New Pride Agenda as Policy Counsel. Our mission is to focus education and advocacy on the most marginalized members of the LGBTQ community, including Black and Brown transgender, gender nonconforming, and non-binary people. A major part of the education and advocacy we do is about the prevalence and prevention of HIV in our communities and the kinds of unique supports they need. I'm here today to talk to you about what the city can do to support them too. Research reveals that the number of older adults in the US living with HIV is the largest ever in history, and that number is going to continue to grow. This is due in large part to advancements in the treatment of HIV, but it's important to note that many are still contracting HIV at a later age. According to the New York City Department of Health and Mental Hygiene, about 17% of new diagnoses are after the age of 50, but the number may grow because many still don't know their status. The Center for Disease Control reports that among older adults, African American and Latinx people were 12 and 5 times more likely to contract HIV, respectively. Because of stigma and assumptions about older adults, many healthcare workers simply don't know how to talk to them about preventing HIV, and it's rare that they're ever offered an HIV test. Contracting HIV at a later age is an especially difficult experience, both emotionally and medically. Older adults living with HIV feel all of the stigma that the younger counterparts do, but they experience it together with ageism and social isolation, resulting in depression, anxiety, and lower rates of adherence to antiretroviral therapies. Currently, many nonprofits and health centers in the city are under-equipped to address the needs of older people living with HIV in their care. To that end, I would like to ask the City Council to step in to help this vulnerable and invisibilized community. One action the Council can take is creating an initiative on HIV and aging and including it in the upcoming budget. Another is lowering the age at which people living with HIV can access older American Act programs to 45. And finally, the city should remove the current upper age limit on the CDC's HIV testing guidelines, which currently only recommends HIV testing between the ages of 13 and 64. Thank you for the opportunity to speak about this issue. Thank you, Faris.
Hi, My name is Cristian Gonzalez Rivera, and I'm the Director of Strategic Policy Initiatives at the Brookdale Center for Healthy Aging. As you know, we're CUNY's Aging Research and Policy Center. So I'm here on behalf of Dr. Mark Brennan Ng, my colleague at Brookdale, who's our research director and a national expert on older people living with HIV and also the psychosocial issues facing LGBT people as they age. So these are his words. We support introductions 825 and 895, which would increase access to and public knowledge about PrEP and expanded STI rapid testing. We also support Resolution 395 and the state legislation that it references. Many healthcare providers mistakenly assume that sexual activity diminishes in later life, leading to a lack of discussions about sexual health with older patients to avoid potential discomfort. Contrary to this belief, research, including my own, Mark's own, indicates that a significant number of older men and women remain sexually active, with health issues or a lack of available partners being the main limitations. When I've spoken to older New Yorkers about sexual health in later life, many are shocked to learn that they may be vulnerable to HIV and other sexually transmitted infections if they are sexually active. The lack of sexual health education as a barrier for older New Yorkers in getting tested for HIV is a critical aspect in addressing the HIV/AIDS epidemic. In 2018, as Farah said, 17% of new HIV diagnoses were in individuals aged 50 and older, emphasizing the need for targeted prevention measures. PrEP emerges as a crucial intervention, particularly for older adults. PrEP is not only as effective as condoms in preventing HIV transmission, but also importantly, it engages older adults in conversations with their medical providers. And for older men with erectile dysfunction, PrEP also offers protection from HIV without having to rely on condoms. And also for older women, stigma around condom use in certain populations also poses challenges. So PrEP also presents an opportunity for them to have a proactive approach to safeguarding their sexual health. Expanding PrEP could also encourage more STI testing among older individuals and serves as a precedent. The City Council's also previous support for sexual health awareness among older adults also serves as a precedent for incorporating PrEP education into existing programs. In particular, programs that were originally funded by the Council and pioneered here in New York City became a national model through the National Older Adults with HIV Initiative, or NOAA. So thank you again for your advocacy and for the opportunity to testify. And of course, as always, we remain available to you as you help improve New York as a place to live for older New Yorkers. Thank you.
Thank you, Christian. Thank you.
Thank you very much to this panel. We'll be moving to our next panel. Dinnick Martinez, Professor Kleinplatz, Reginald Brown, Mike Howard, and Annette Tomlin.
If the light is on, you're good to go.
It's red.
Okay.
Okay. I'll go first. Okay. Good afternoon. My name is Annette Tomlin, and I am over 60, and I am aging gracefully, and I am thankful. And while I am grateful for the opportunity to speak and be heard, it troubles my heart and saddens it to know that people who are living and aging with HIV are still facing the lack of adequate funding to have programs to address the issues that they are so much concerning, to have a better and ensure a quality of life. In New York, 75% of people that are living with HIV are at least 40 years old, and 50% are the age of 50 and over. I'm quite sure that these numbers have increased. This here data was actually in December of 2021. We are facing and upcoming 2024. And while I am thankful for all the opportunities that, and advancements rather, that have been occurring since the beginning of the AIDS epidemic, and because of the medication, and we have longevity, or longevity, it's like, how do you not have a plan for people to actually be able to have a substance and better quality of life? The prevention and programs that are needed, it's not rocket science. There have, cutbacks, and we just heard this, that Mayor Adams is going to have more cutbacks. We have to push for more monies to actually be funded. Collaborations need to occur with all the persons that have spoke here today, a collaboration of organizations that are able to provide better services for persons. I am a vocal leader. I fight and I advocate. So I thank you all for this opportunity to speak, and I look forward for us to all be able to make a difference and a change, because the next generation, we don't want to have to face what they had to face from our prior era. Thank you.
Thank you, Annette.
Hi, can you hear me? Hi, my name is Daniel Martinez. I am proud atheist. I hope the City Council State Committee on the separation of church and state, as it is in our U.S. Constitution, which New York City, including the state and even the federal government, have violated that right. I want to say that, as some previous members have spoke, I have to say that HIV is not over and is here to stay, just like a COVID-19. Anyone can get HIV/AIDS virus. Christians, Jewish, Muslims, atheists, agnostics, including lesbian, LGBTQ, straight, anybody can get HIV. HIV does not discriminate. Libertarians, independents, Republicans, Democrats, just you Republicans, you can get HIV too. HIV does not discriminate. All backgrounds, religion, non-religion, citizens, non-citizens, race, black, white, Chinese, anybody can get HIV. One thing that I'm also, one thing that I silly is not listed here, but as you know, our council member, Kristen Hudson, is in her district. I'm a member also of the Rainbow Heights Club, and I hope that you work hard for them not to cut the funding, because these organizations provides, clients are so happy with this program. And yes, there's a lot of LGBTQ elders. I believe, I don't have the statistics, but based on what I see people there, 30% or more are elders, and even elders, immigrants without papers who have been here for 20 or more years, also they need help too. They need to be housed. Thank you.
Thank you so much, Danik. And I'm a big fan and supporter of Rainbow Heights Club, so thank you.
So I hope they don't cut the funding, because that will be devastating.
Absolutely, I hope not either.
And actually, I want them to raise from the $4 to $5 that what they give every day people go there, so I want them to raise it. I would like to talk to you later.
Okay, thank you.
Thank you. Can I get your business card or something?
I'll make sure we get your contact information.
Thank you.
Thank you.
Thank you very much to this panel. We're going to be taking a quick break to go to a Zoom panel. So we're going to be hearing from Finn Brigham, Katie Bordonaro, Kay Greenberg, Amir Sadeghi, Antonio Urbina, Jason Price, and Chris Norwood. We're going to start with Finn Brigham. You'll each have 2 minutes for your testimony. Please wait for the Sergeant at Arms to call time before you begin your testimony.
Time starts.
Thank you. Good afternoon, and thank you for holding this hearing. We share your passion for discussing how New York City can increase access to services for New Yorkers aging with HIV. My name is Finn Brigham from the Callenor Community Health Center, Callan Lord provides healthcare services, including gender-affirming care, focused on New York City's LGBT communities. We are the largest PrEP provider and one of the largest non-hospital-based TGNB healthcare providers in the state. I want to begin my comments by acknowledging, as so many folks have, that adults living with HIV are living longer lives. According to a Gilead study in 2021, adults living with HIV are living well into their 70s and 80s. While this is good news, we are now seeing a growing population enter their elder years without proper support and access to resources. We are seeing a growing number of older adults that are still dealing with decades-long trauma that has not been fully addressed. Many of these patients lost dozens of friends and lovers to HIV. Many of them have very few friends left and have not truly processed the trauma this epidemic has caused them. At Callan Lord, over 30% of the patients we serve are over the age of 50, and roughly a third of our patients are HIV positive. Many of them have expressed deep fear about having to choose between leaving their LGBT competent healthcare with us and transitioning to receive aging competent healthcare elsewhere. They have asked us for longer appointments, a more robust referral system that includes LGBT competent specialists like cardiologists and geriatricians. They've talked about needing assistance to navigate Medicare and the fear that nobody would look out for them as they age because they are less likely to have children. We've listened to our aging patients, and we are responding by taking serious steps to ensure that our patients have the option to stay with Callan Lord as they age. We recently received an $180,000 grant from the Fan Fox and Leslie R. Samuels Foundation to support this work. We started a program called Prime Time for patients over 50 with HIV. We became a designated age-friendly health center through the Institute for Healthcare Improvement, and just this week we hired our first clinical director of elder care. I want to share some recommendations that we believe can help address some of these concerns. We need to increase HIV testing rates among older adults. We need to improve care coordination services that address the physical and mental health for older adults living with HIV. And we need our policy leaders to invest more financial resources to support organizations like us focusing on this care. I'd like the record to reflect that Callan Lord supports all the bills and resolutions on the agenda in front of the committee today. Thank you.
Thank you, Finn.
Thank you. Now we'll be moving to Katie Bordenaro. Please wait for the Sergeant at Arms to call time before you begin your testimony.
Time starts.
My name is Katie Bordenaro, corresponding secretary of the Mitchell-Lama Residents Coalition. And while we support all of the legislation you're discussing today, I would like to talk about Reso 0791, which Gail Brewer is sponsoring. Founded in 1972, the Mitchell-Lama Residents Coalition works with current co-op and rental complexes in the program and also former Mitchell-Lama complexes and residents who are all eligible for the programs in Reso 0791. The resolution calls for the New York State Legislature to pass and the government to sign Senate Bill 2960 and Assembly Bill 5741 to provide for the annual adjustment of the maximum income threshold for the senior citizen rent increase exemption, disability rent increase exemption, senior citizen homeowners exemption, and disabled homeowners exemption by any increase in the consumer price index. MLRC has supported the passage of this legislation for many years, and we're grateful for Gail Brewer's sponsorship this year. Many of the residents of Mitchell-Lama developments are senior citizens, some are disabled, and these groups need the protection from rent increases that that these exemptions provide. And this would also apply to rent-stabilized apartments and to many of the people who are talking today about the need for housing. The importance of this annual cap increase has been shown in the last few years when inflation has driven up so many prices. The groups covered by these exemptions are generally on fixed incomes, and they're already stretched thin in facing the prices of basic necessities. This income cap was last raised in 2014 to about $50,000. If we'd had these consumer price index adjustments, the cap would now be $69,000. So we really need this legislation, and we hope that the council will support Reso 0791 as a step towards getting it. Thank you.
Thank you, Katie.
Thank you. We'll now be moving to Kay Greenberg. Please wait for the Sergeant at Arms to call time before you begin your testimony.
Time starts.
If you take anything away from this testimony, please remember this: disparate impact, syndemics, comorbidity, underserved, marginalized. These phrases all allude to intersecting structural barriers in all of our government and private systems that block aging Black and Brown LGBTQ+ New Yorkers living with HIV from accessing life-saving information and services that already exist. My name is Kay Greenberg, my pronouns are he, him, and I am a staff attorney at the Center for HIV Law and Policy, an abolitionist legal and policy organization that fights to end the criminalization of and the stigma, discrimination, and violence directed towards people living with HIV. So what does it truly mean to say that aging Black and Brown New Yorkers living with HIV are blocked from services? As of 2021, over 50% of people over the age of 50 in New York living with HIV are Black men. 1 in 5 Black men will be incarcerated in their lifetime. LGBTQ+ folks at a high risk of incarceration due in part to commission of survival crimes, and 42% of Black trans women are living with HIV. The Venn diagram of these statistics means that likely a large section of people aging with HIV in New York have criminal records. These New Yorkers have to navigate the collateral consequences of these records, such as the limits, if not bans, on access to housing and public benefits. We also know that New York is facing a housing crisis. Many other people mentioned that today. That the demand for reasonably priced housing, if not low-income housing, far outstrips availability. That fair market rents for Section 8 voucher holders relegate them to the under-resourced corners of the city. That our elderly population is being gentrified out of neighborhoods. That Black and Brown people are legally discriminated against by landlords, and that previously incarcerated people are at a high risk of housing instability. And that having stable housing is a necessity for good health outcomes. It's hard to age in place without a home. When discussing the needs of aging people living with HIV, there is commonly a focus on medical interventions and improving access to culturally competent, fully transparent, and consensual testing in medical care that increases trust in medical providers, particularly for Black and Brown New Yorkers, is essential. But better health outcomes for aging New Yorkers with HIV can only truly be achieved through addressing the barriers, such as the collateral consequences of criminal records that make Black and Brown New Yorkers vulnerable in the first place. Thank you for your time.
Thank you so much.
Thank you. We'll be moving on to Amir Sadeghi. Please wait for the Sergeant at Arms to call time before you begin your testimony.
Time starts.
Hi, thank you. My name is Amir Sadeghi. I use he, him pronouns. I'm the Policy and Advocacy Manager at CHLP. My colleague Kay actually just touched on a very important topic, which is cultural competency or cultural humility. And we know that older people are receiving late or concurrent HIV/AIDS diagnoses in unacceptable numbers here in New York, which is a reflection of those structural barriers to care that have been discussed today. But I think it's also a very clear result of providers making assumptions about what kind of sexual activity older people are engaging in, or making the outright assumption that older people are not sexually active at all. So testing is important to address this issue. But protecting informed consent and direct notice prior to HIV testing, which is enshrined in the public health law, is paramount to ensuring medical ethics, bodily autonomy, informed consent, and patients' rights. Informed consent is what enables trust to exist between our health system and marginalized patients. However, it is clear we need some solution to build on affirming healthcare while protecting patients' rights. CHLP is working with a coalition of LGBTQ and HIV justice organizations to make New York the first state in the country to universalize continuing medical education on sexual orientation and gender identity, HIV and STI testing, and sexual health literacy. Assembly Bill 282, introduced by Linda Rosenthal, soon to be introduced by Senator Jessica Ramos, would advance health equity for all New Yorkers. It will especially advance the health equity of LGBTQ New Yorkers. But this continuing education will directly impact older New Yorkers. It will help providers feel more comfortable talking to older people about sex and health and fulfill their legal obligation to directly offer an HIV test to all adults. So my ask is, please, I would ask that this committee and the New York City Council pass a resolution in support of Assembly Bill 282 to universalize continuing medical education on sexual orientation and gender identity and HIV and STI testing, and build and champion LGBTQ affirming healthcare and patients' rights. Thank you.
Thank you, Amir.
Thank you. We're now going to move to Antonio Urbina. Please wait for the Sergeant at Arms to call time before you begin your testimony.
Time starts.
Okay. Good afternoon, everyone. Thank you so much for the opportunity to speak. My name is Dr. Antonio Urbina. I am a professor of medicine at the Icahn School of Medicine at Mount Sinai and have over 30 years of experience treating patients with HIV, and I currently serve as the medical director for the HIV and Primary Care Center of Excellence of the Clinical Education Initiative of the New York State Department of Health AIDS Institute. And early in my career, I treated patients with severe opportunistic infections at the height of the HIV epidemic at St. Vincent's. I was at the forefront of applying cutting-edge antiretroviral therapies from clinical trials. And from 2007 to 2009, I served on the Presidential Advisory Council on HIV/AIDS, advising the White House. And more recently, from 2014 to 2015, I served on Governor Cuomo's task force to end the AIDS epidemic in New York. And with this background, I'm here today to speak about the important issues of HIV and aging. And as someone who's really dedicated his career to HIV care and treatment, I understand the unique challenges facing older adults living with HIV. We've made great progress in HIV treatment and care, but more needs to be done to support this vulnerable population. As people with HIV live longer, they are experiencing higher rates of comorbidities, social isolation, mental health issues, and importantly, financial insecurity. The city must take action to address these needs through expanded services and programs tailored to older adults with HIV. And I strongly urge the council to make this a priority by creating and funding a new city council initiative on HIV and aging in the fiscal year 25 budget. This initiative would provide vital resources to two types of organizations that serve people with HIV, medical organizations and community-based organizations. The funding could support services offered by both types of organizations, including case management, mental health services, self-management programs, skills training, peer support groups, and importantly, exercise and physical therapy programs. Investing in the social and medical needs of those aging with HIV is both a moral imperative and a wise long-term strategy. And I really want to thank the council for allowing me to speak today.
Thank you, Dr. Urbina.
Thank you very much. At this time, we'll be moving to Jason Price. Please wait for the Sergeant at Arms to call time before you begin your testimony.
Time starts.
Jason Price. Okay, we will be moving on then to Chris Norwood. Please wait for the Sergeant at Arms to call time before you begin your testimony.
Time starts.
Good afternoon. Thank you for these hearings. I'm Chris Norwood, Executive Director of Health People in the South Bronx. I want to focus on comorbid conditions, particularly diabetes. In a 10-year study, people had HIV had a 3.6% death rate. When they had diabetes, it was 12%. And when they had diabetes with chronic kidney disease, which is very much caused by diabetes, the death rate went up to 36%. I'm a bit distressed not to have heard more focus on these kinds of conditions during this hearing. I think another part that's really important to look at is a lot of what you're calling mental health conditions is actually, once again, high sugar rates are a major driver of Alzheimer's disease. And of course, the rate of diabetes in people who have HIV is quite high, and it goes up higher after they're age 50. We have come to the council many, many times and beg them, just beg them, to start diabetes self-care programs peer-delivered in communities. And we have pointed out many times that during the 25 years that diabetes has been the most widespread epidemic in New York City, the council has not funded any community programs whatsoever. We can see the results everywhere in every disease. It's particularly disastrous in HIV. I want to just give you an idea of what's being lost by not giving people group self-care programs that they like, that overcome their isolation. When people with diabetes have their blood sugar even in moderate control compared with poor control, their Alzheimer's risk goes down by 30%. If it's in good control, it goes down by 60%. In the HIV population, while we don't have, thankfully, the terrible AIDS dementia we had at the beginning of the epidemic, about 30% of people with HIV develop neurocognitive disorders over time. It is therefore even more important for those with diabetes to learn how to properly control their blood sugar, because that will lessen the impact of these neurocognitive disorders. I really want to, with the chairs speaking with their concerns for mental health, isolation, and socialization, this is what peer groups do. But in this case, these peer groups not only improve physical health, they protect mental health, they protect brains, and this population desperately needs to have that protection. Thank you.
Thank you so much.
Thank you very much to this Zoom panel. We're going to be going back to an in-person panel now. I'd like to get Jan Carl Park, Sam Joe Kleinplatz, Michelle Veronica Lopez, Asia Betancourt, and Cameron Craig, please. And Mr. Kleinplatz, we can start with you.
Okay, you can hear me, right? First, let me thank all of you, because this has been an absolute tragedy. My roommate has been missing for months and months and months. There is extensive litigation against Bellevue Hospital. I have been made a non-human being with no rights. I have been taking care of Rafael Rosa for over 40 years. The attorney of record is Paul Curson. Thank God the judge found Rafael. He was dumped in a nursing home, Highbridge Woodycrest, which is not indicated for his condition. He has mild dementia. He can easily be treated at home. The nursing staff advised, do not put him in a nursing home, and that's exactly what they did. We would not even have an apartment if it wasn't for Counsel Robert Goldberg. That can also be, you can also check that. I'd like the council to get a copy of the videotape where Rafael was torn away from me. I've lived with him for 40 straight years. He is one of the most beautiful human beings that provides no problems to anybody at the hospital. The nursing staff begged that he not be put in a nursing home, and that's exactly what happened. As a result of my telling the truth, the Guardian has retaliated, and I've sent a number of the electeds the response. She retaliated against me for demanding answers from the Highbridge Woodycrest nursing home. The borough president's office, namely Vanessa Gibson, got involved. Get to the bottom of it. I repeat, this is not a proper placement for him. He needs to be home. His nursing home does not treat his condition. Let me reiterate that the Alzheimer's Association has found the case of Rafael Rosa to be one of the most awful, horrendous cases they have ever reviewed during the entire time that they're an agency. They decided to resend him for Bellevue for medical care. Let me please finish. That needs to stop. That's exactly the traumatizing agent, the traumatizing facility. I should remind you there are over 1,500 medical clinics in the Bronx that could have easily treated him. As a result of my bringing this up, the Guardian, who has never visited him except for once, who has never checked in on the fact that all his earthly possessions are gone, that he was in somebody else's pants, torn slippers. It is entirely inhumane. I therefore am calling on all of you to notify the governor that the guardianship system, which is being abused, needs to stop. And we need to stop putting people who are HIV positive or otherwise in nursing homes. They can go back to their home health care, which Narcissus said. I'm saddened by one thing, that some of the people that really can make a difference, although I rest confidence in Councilperson Hudson that she will not let this continue, that this will end. The governor has to stop this guardianship nonsense and the guardianship abuse. I am going to also, as part of the record, give to the committee council the names of each one of the attorneys that, thank God, have interceded. We would not even know if he was alive. When one member of the mayor's office and one member of the state assembly told me that he didn't want any visitors, we were able to get somebody in briefly. Two witnesses, Pablo Valentin and Ossé Orozco, and Rafael said, no, I love my grandchildren. I want to see my grandchildren. I love my children, and I love all of you. We have not been able to see him. This has to stop. This is probably one of the worst cases, again, I reiterate. This cannot continue. HHC has to be held accountable, and New York State Department of Health has to be held accountable, including on-site visits. They responded to me by saying they're going to do an off-site visit. It's useless. You need to go in there and do on-site reviews of all of these hospitals and the guardianships and get to the bottom of why people are being put behind guardians who have families. Rafael has a daughter. Rafael has a son. Rafael has thousands of cousins who came, and guess what? They were thrown out of the hospital. They weren't allowed to see him. Finally, last but not least, I went to ask the nursing home director, Leon, whether I can hug him for one last time. And do you know what he said? No, you cannot. Leave. You need to leave now. So I'm calling on you, especially Councilperson Hudson, to make sure that I can see him at least at Thanksgiving and definitely at Christmas. Thank you both, and thank you all, actually, including council.
Thank you so much for that. I'm sorry that you're going through that experience. We'll be sure to follow up.
Thank you. I know you will.
Hi. I'm Jan Park, a former New York City government employee working at the New York City Health Department. I am the former chair of the HIV Health and Human Services Planning Council. I also worked for 10 years in the mayor's office across the hall in the Office of AIDS Policy. And I'm here today to talk about retired New York City government employees who are HIV positive and the challenges that they face. I retired from government service on World AIDS Day, December 1st, 2019. I believe one of the biggest challenges to elders living with HIV who live on a fixed income are the costs of health insurance and prescription drug coverage. For those who qualify for Medicaid, the costs for a doctor's visit and related lab work are covered, but Medicaid Advantage plans is necessary to cover other expenses, such as prescription drug coverage. Today, there are over 350,000 active members and retirees of the New York City retirement system. A dozen health insurance plans for retirees are made available to them through the Office of Labor Relations health benefits programs, all with catastrophic coverage limitations. What does that mean? For me, it means by the 5th of the year, I enter catastrophic coverage, which requires me to pay 5% of the retail cost of prescription drugs in the highest tier categories. All HIV medications are in the highest tier category. This means that I pay, when my prescription plan catastrophic coverage kicks in, I pay $1,140 per month, or $9,130 for 8 months for my HIV medications. For those facing retirement, choosing health coverage, insurance, and prescription drug coverage plan that's affordable can be onerous. I believe that much good could come from the City Council review, assessment, and adjustment to catastrophic coverage limitations that are part of the packages offered city retirees through health insurance and prescription drug coverage plans. Thank you.
Thank you so much for your testimony.
Thank you very much to this panel. At this time, if there's anyone in the room who wishes to testify and you have not had your name called, please fill out an appearance card. You can get one from the Sergeant at Arms. Okay. Not seeing any. We'll be moving on then to Zoom panelists. So we're now going to hear from Jules Levin. You'll have 2 minutes. Please wait for the Sergeant at Arms to call time before you begin your testimony.
You may begin.
Hi, can you hear me?
Yes.
Thank you. So with everything that's been said today, I will try and narrow down my comments. So I'm the person that first discovered the aging problem 17 years ago in HIV and worked with the NIH and the Office of AIDS Research. And 5 years ago, approached New York City, or 6 years ago, about this. And I'm the one that worked with the city to design the Be In There aging clinics they're talking about. And very briefly and succinctly, let me tell you that they're not working. Most people with HIV who are older and elderly are not getting the care needs met in clinics. So I'm a person, I'm 74 years old. I'm the executive director and founder of the National AIDS Treatment Advocacy Project. I've led the way for 17 years on research and education and discussion and policy around aging and HIV. And about 6 years ago, I approached the city and then the state. And as was said earlier today, the city and the state and nationally, our HIV clinics are totally unprepared to deal with the aging problem today. As said today, rates of comorbidities like heart disease and cancers are much higher for people with HIV, including frailty and cognitive impairment. I've lived with HIV for 40 years. I get my care at a major Ryan White clinic here in New York City, and in no uncertain terms they do not provide the care needs I need. It's 15-minute visits in and out. The portals don't work. Communication with doctors are inadequate. Most doctors don't. In fact, most clinics and Ryan White clinics do not provide geriatric screenings for older people, which is bone mineral density testing, frailty testing, and cognitive impairment testing. So I think a lot of what you heard today was the smoke screen. A lot of what you heard today was a smoke screen, and not really the truth about care for elderly in the city today.
Thank you very much. At this time, we'll be moving on to Mohammed Amin. You'll have 2 minutes for your testimony. Please wait for the Sergeant at Arms to call time before you begin.
You may begin.
Thank you so much. Good afternoon, Chairperson Hudson, Narcisse, and Showman. My name is Mohammed Q. Amin. I'm the Executive Director of Caribbean Equality Project, a Caribbean LGBTQ immigrants' rights organization that represents Afro and Indo-Caribbean immigrants in New York City. I will submit a written testimony, but I wanted to share a bit of the following today. Caribbean Equality Project fully supports and calls on the Council to pass this session all the bills discussed in today's hearing. New York City is home to the largest Caribbean foreign-born population, many of whom live in Caribbean-centric neighborhoods like Richmond Hill, South Ozone Park, and Far Rockaway in Queens, Flatbush and Crown Heights in Brooklyn, Castle Hill, Wakefield, and Soundview in the Bronx. The Caribbean LGBTQ immigrants Caribbean Equality Project serves face unique challenges, and health inequity should not be one of them. Many of the barriers queer Caribbean immigrants encounter range every day from HIV stigma to lack of access to culturally responsive healthcare and mental health resources. Many of the organization's clients are asylum seekers, low-income and undocumented queer and trans Afro and Indo-Caribbean people of color. Many of the barriers queer Caribbeans encounter are rooted in ancestral trauma, recovering from post-colonization, LGBTQ-related phobias within faith-based institutions and diaspora Caribbean communities, HIV discrimination, and lack of access to culturally competent mental health care resources. Health services have been an essential component of Caribbean Equality Project advocacy for the past 8 years. Stemming from the need for increased access to free STI and HIV testing, we noticed in our service to community members, particularly asylum seekers who left the Caribbean to live in New York City. This correlates with the DOH-MH data. According to the 2018 New York City Department of Health and Mental Hygiene HIV epidemiology research, the highest incidence of new diagnoses for HIV
Your time has
are
expired.
among foreign-born
Thank
New Yorkers, and these folks were primarily from Caribbean countries, including the Dominican Republic, Jamaica, Haiti, and Guyana. Currently, Richmond Hill is home to the largest Guyanese population in New York City, and our community has no access to HIV and testing. So today, we are here to call in the City Council to pass Intro 895, Intro 620, Intro 825, Resolution 294, and Resolution 395, so we can live safely and protect each other while living healthy lives with dignity. Thank you.
Thank you so much, Mohammed.
Thank you very much. At this time, we're going to hear from Jonathan Martinez.
You may begin.
Okay, Jonathan is not available. Moving on to S. Hayes.
You may begin.
Moving on to Olga Cotto.
You may begin.
Moving on to Lisette Velez.
You may begin.
Moving on to Mary Oliver.
You may begin.
And finally, moving on to Sabina Adhikari.
You may begin.
At this time, if there is anyone on Zoom who has not had their name called but who would like to testify, please indicate so using the Zoom raise hand function. Seeing no hands, turning it back to the chair for closing remarks.
Thank you so much to everyone who has testified today, both in person and via Zoom. I think all of the testimonies we've heard are testament to the strong need that there is for services and resources across every sector, not just specifically for healthcare, but also housing and social services for older adults living with HIV. I also want to reiterate the fact that representation really does matter. 2 out of the 3 host chairs today identify as LGBTQIA+, and 2 out of 3 of us also are Black. And I think the fact that we haven't had a hearing on this topic in almost 20 years shows that we haven't had representation in the past that would prioritize a topic such as this one. So I thank everyone again, and especially the staff, for making today's hearing possible, and this hearing is adjourned.